เพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทาง
So I will invite all of you to be in the room because we will start the meeting soon. Okay.
ส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลัง นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย
Okay, good morning everyone, ministers, distinguished guests, ladies and gentlemen. My name is Watini Kunpyeok, a coordinator of this meeting and a researcher of the International Health Policy Program, or IHPP Thailand. It's my great pleasure to welcome you to the PMACSI meeting, SMB 111, Strategies to Address Health Inequity and Promote Inclusive Health Systems for Migrants, Lessons from Malaysia, Singapore, and Thailand, with potential applications to other countries. This meeting is part of the research project, Analysis of Policies to Address Health Inequity among Low-Income Migrant Populations amidst the prolonged COVID-19 pandemic, Malaysia, Singapore, and Thailand. This meeting's success relies on the invaluable support from our partners, so we would like to thank our co-hosts, including the International Health Policy Program, or IHPP Thailand, the Asia Pacific Observatory on Health Systems and Policy, or APO, the Country Cooperation Strategy Migrant Health Program, Thailand, the Thai Health Promotion Foundation, the Health Systems Research Institute, or HSRI, Thailand, the Ministry of Public Health, Thailand, and the International Organization for Migration, or IOM. Today we also have Facebook Live, and I also welcome everyone who join us online, who may be from your home or your workplace. First of all, I would like to invite Dr. Rapipong Supanchaimat. He is the director of the International Health Policy Program, or IHPP Thailand, to deliver welcoming remarks. Please, Dr. Rapipong. Okay, yeah, we can hear you clearly ค่ะ
Okay น่าจะขยับนิดนึงเนาะ So good morning everybody and all distinguished delegates. Today is a pleasure of the International Health Policy Program, which is the host of this meeting, to organize the session on migrant health, and we aim that first of all, I would like to thank all the distinguished delegates for your participation. I know that some of you are from abroad, some of you are from Thailand, and I think this is a good opportunity for all of us to learn from each other, especially in relation to the issues of migrant health in Southeast Asia. I also would like to express my sincere gratitude to the PMAC Secretariat and also the organizer of this meeting to arrange this session, because it is quite difficult for us to meet each other in person, especially in relation to the international conference like this. I hope that you'll be successful in this meeting, and I think that this meeting will not be a one-off discussion. After this discussion, I foresee that there will be many things to do, many things to move forward. However, this is a good kickstart. I don't want to eat up your time because I find out in the agenda that there are many agenda topics that you need to succeed. Therefore, in this regard, I would like to declare this meeting open. And like I mentioned earlier, I hope that you will have a productive discussion, and I do hope and I wish that you will have a successful meeting. This is one-day meeting, right? And not just that. And as I mentioned earlier, this is not the one-off meeting. Your success is not just the finish of this meeting, but also to identify the ways forward to work with each other. Thank you, Krab.
Okay, thank you so much, Dr. Rapipong. Next, I would like to invite Dr. Supakit Sirilak. He is the Executive Director of the Health Systems Research Institute, or HSRI, Thailand. Please, Dr. Supakit, the floor is yours.
Excellency, distinguished delegates, ladies and gentlemen, very good morning, Sawadee Krab, and very warm welcome to this PMAC side meeting, strategy to address health inequity and promote inclusive health system for migrants. Let's learn from Malaysia, Singapore, and Thailand. With potential application to other countries, the objective of this meeting is to disseminate the finding of a study on the analysis of policy and long-term strategies to address health inequity and problem inclusive health system for migrants in Malaysia, Singapore, and Thailand to wider audiences in ASEAN. I hope that this narrative can be highlight what we should do next for ASEAN after our hard time during the pandemic. And it could be applied to other ASEAN contexts. During the COVID-19 pandemic, many migrants faced challenges in the equitable and inclusive health policy implementation. Consequently, there is a need for more comprehensive guidelines and practices to safeguard migrant population, particularly during crisis. This is a need to narrow the health system gaps between local citizens and migrant population. We have the data that in Thailand, migrant workers who working in Thailand contribute around 6.2% for the Thailand GDP. So this is quite important in the economic aspect also. During the COVID, moreover, legislative and non-legislative intervention for migrant health protection should be improved. Sustainability of healthcare financing and financial contribution from various sources should be part of the long-term plan in response to emergencies. Primary healthcare and public health intervention and the local level should be tailored and culturally sensitive with increased engagement of representatives from the migrant health community and migrant health volunteers. Public health communication, including risk communication strategy, should be conducted in migrant-friendly languages. Implementing evidence-based and right-centered approach to risk communication should be performed with caution to prevent issue of discrimination and xenophobia against migrant population. Working on migrant health is a long way, and collaborative efforts are key to our progress. In the afternoon session, there is an opportunity for all of you to engage in discussion, sharing your ideas and key issues that need collective attention. This includes barriers and enable to access to healthcare services in migrant communities, working conditions, and migrant health. So your experiences and insight during the discussion will be valuable input for us. As a result, we aim to see it as a draft policy recommendations to further inclusive migrant health policy in ASEAN, with a particular focus on health inequity among migrant population in accordance with the ASEAN Health Cluster 3 on strengthening health system and access to care. I am confident that together we can advance the migrant health agenda and improve the life of millions of migrants in our region. There are plenty of assignments to be done, and I look forward to collaborating with all of you, united by our shared ambition, which is and also common goal. So thank you very much and have a pleasant day. Thank you.
Thank you so much, Dr. Supakit, for your opening remarks and general support. Before moving to the presentation, I will propose a brief session for a group photo and the distribution of souvenirs to our speakers, moderators, and rapporteurs. To kick off this session, I would like to invite Dr. Supakit to be our chair and present the souvenirs to each of our speakers, moderators, and rapporteurs. First, I would like to invite Dr. Supaporn Setadan, please. Professor Huso Yi. Invite Dr. Panuwit แก้วคำจรชัย Next, I would like to invite Miss Tamsin Fernandez Cox. Dr. Momen Nader. Thank you. Next, I would like to invite Miss Amira Safira Sani. To invite Miss Aisha Fawin. We would like to have a group photo on the floor first, please. Okay, thank you so much. For the next presentation, we will go for the overview of on the regional cooperation to improve migrant health in ASEAN. For this session, it's our great pleasure to have a presenter by Dr. Supaporn Sethadan. She is the vice of the ASEAN Senior Officials Meeting on Health Development, or SOMHD, Chair and Vice Permanent Secretary of the Ministry of Health. And I would like to welcome Dr. Supaporn for the ASEAN presentation. Please, the floor is yours.
Good morning, everyone. Excellency Supakit Sirilak, Executive Director of the Health System Research Institute of Thailand, distinguished representative from Ministry of Health, ASEAN member states, distinguished representative from IOM and academic, ladies and gentlemen. On behalf of the Senior Officer Meeting Health Development, Chair of Lao PDR, I wish to thank the organizer of the meeting to invite some HD Lao PDR to present the relevant outcome of the ASEAN health sector framework on the health coverage, documented migrants, including the migrant workers and special population. Next slide, please. May I have next slide, please? Thank you. For this presentation this morning, allow me to present the ASEAN Post-2015 Health Development Agenda 2021 to 2025. Milestone migrant health priorities of the ASEAN health sectors, migrant and health ASEAN region case study, ASEAN framework on the health coverage of the documented migrants, including migrant workers and the special population. Next slide, please. Just to brief the overview of the ASEAN Post-2015 Health Development Agenda for 2021 to 2025. The migrant health side in the overall priority of the ASEAN health sector. Next slide, please. The vision and mission of the ASEAN health sector is operationalized in the ASEAN Post-2015 Health Development Agenda, or APTA, for 2021 to 2025. As shown in the ASEAN health sector vision is to have the healthy, caring, sustainable ASEAN communities, and the mission to ensure the healthy, caring, and sustainable ASEAN community by priority health lifestyle, responding to all hazard and emerging threats, strengthening health system and access to care, and ensure food safety. The vision and mission of the APTA contribute to the align with the socio-cultural community blueprint of the ASEAN. Next slide, please. To achieve the vision and mission, the APTA is realized through the ASEAN Health Cluster, their goal and their work programs. The APTA 2021 to 2025 was adopted by the ASEAN Health Minister during the 15 ASMM on 14, 2022. The most relevant to the Migrant Health ASEAN Cluster 3 on strengthening of the health system and access to care, as highlighted on the screen. Next slide, please. There are 21 priority of the ASEAN health sector, and 17 is on the migrant health. To realize this priority, collaboration with the other ASEAN health cluster and sectoral body, such as the labor sector, is pursuing migration is cross-cutting area and cooperation in the ASEAN. Migrant health is the health priority under the Health Cluster 3 work programs under the theme of the service of the special population and where universal health coverage is addressed. The work program objective related to the health priority is to enhance health system capacity and capability to seek the improved service for the documented migrants and including migrant workers, mother, women, and children. This is the special population. Next slide, please. Under the current Health Cluster 3 work programs, there are 7 health priorities and 55 projects and activities to be implemented in 2021 and 2025. 8 of these activities fall under the health priority on migrant health. The IOM remain to be the development partners of the Health Cluster 3 in pursuing migrant health-related activities under the work programs. Under this, there are two terms of the Health Cluster 3 operationalized. One is Health Cluster 3, definition of the migrant worker, which is obtained from the ASEAN Consensus on the Protection and Promotion of the Rights of Migrant Workers 2017. The second is the definition of the spatial population, which comprise document migrant, including migrant workers and the spatial population. This term is also defined in accordance to the AMS context and pairing national law and the regulation of the AMS. Next slide, please. The regional interest and work on the migrant health began prior to the programmatic approach to addressing health concerns in the ASEAN. Through the ASEAN Strategy Framework on the Development 2010 to 2015 Regional Strategy, envisioned to be undertaken two high-level meetings on the migrant on HIV/AIDS were also conducted in 2009 to 2011, which engaged the migrant health focal point from the ASEAN. And in 2012, workshop on the migrant health ASEAN country was conducted to realize the output. However, this is overtaken by other health priorities. Next slide, please. In this ASEAN post-2015 development agenda, 2016 to 2020, the development of the ASEAN framework on the migrant health was made part of the work program Health Cluster 3 and was led by Philippines and co-led by Indonesia. This paved the way for the development of the ASEAN framework on the health coverage of the document migrant, including the migrant workers and special population, where two workshops were conducted to develop the framework. The work proceeds through the iterative feedback from the AMS until was finalized. Next slide, please. This also led to the concurrent development of the migrant of the health ASEAN. Regional case study with the support of the IOM. We would like to especially thank IOM Regional Office for Asia Pacific Migrant Health Team of the IOM for their patience and speed up support. Involve and scoping review of all relevant database, literature, research related migrant health in the ASEAN. They were collected and analyzed by IOM. It's carefully detailed each member state overall general country profile, migrant profile, health governance and financing, structure, health service, delivery mechanism, and identify each member state key challenge to improve the migrant health policy and strategy. Consultation were done over a period of time and final approved was obtained from the ASEAN Health Minister meeting and was adopted on 8 January 2024. Next slide, please. The Migration and Health ASEAN regional case study served as one of the base for developing an ASEAN framework like case study. The ASEAN framework was endorsed by Health Cluster 3 and Senior Officer Meeting Health Development or SOMHD, and was later adopted by the ASEAN Health Minister on 8 January 2024. Next slide, please. To contextualize the ASEAN framework, the objective state recognizing the importance of the achieving of UHC. This framework set out mutually agreed principle, strategy, and priority to guide the AMS in their policy and the regulatory approach, as well as in the pursuit of the regional cooperation toward ensuring the health coverage for documented migrants, including migrant workers and special population. Next slide, please. No, can you come back? Sorry, in the slide maybe already done, but can you go back? Yes. For the vision of the framework, ensuring achieving the USC where no one is left behind, and the mission of the supporting by the scope of framework, the scope as the title special, the coverage document migrant, including migrant workers and special population, mother and children among them, is adopted definition of the migrant worker under the ASEAN consensus on the protection of the promotion of the migrant worker and the coverage migrant worker who are documented and who are become undocumented through no fault of their own based on the ASEAN consensus. Future finalized in the framework is to operational definition of the special population include in the ASEAN Health Cluster 3 work program for 2021 to 2025, which was adopted in the 15th ASEAN Health Minister meeting on May 2022. Special population is refer to the work program to comprise document migrant, including the migrant worker. The framework identifies four strategic priorities, namely health governance, which highlight the establishment of the appropriate regional cooperation mechanism in addressing the migrant health concern through the designation of the focal unit on the migrant health in the each AMS and network mechanism for the regular communication of the migrant health concern among AMS and to build the technical and management capacity of the focal unit. Health service delivery is under the scope and the need of provide the inadequate, accessible, affordable, and equality medical and health service for the documented migrant in the all AMS through the promotion of the coordination on pre-departure health requirement for the migrants, definition of the essential health service package for the migrant, including the emergency care facility community of the care through the approach and referral mechanism, and increase the health and awareness and health literacy among migrants, including the occupational safety and health protection and migrant workers. Health financing, which highlighted the need to ensure financial risk protection through the provision of the, appropriate health coverage to the migrant with consideration to the existing health financing system to the AMS. So next slide, please. The ASEAN framework also specific that it is non-binding document that is a living document, and that there is going to be a plan of action implementation, the framework, and is regular monitoring. Next slide, please. As presented in the 17th Senior Officer Meeting on Health Development, the following are the agreed next steps to move the ASEAN framework to action. Philippines with goal-led Indonesia shall collaborate with AMS in developing and finalizing plan of action that will provide the consensus concrete activity toward implementing of the framework. Goal-led country to join draft of concept note of the plan of action of the ASEAN framework, and consultation workshop will be convened to discuss the plan of action AMS and finalize the plan, and also propose to continue collaboration with the IOM in the implementation of the ASEAN framework. Next slide, please. Next. So you can see here this link to the migration and health in the ASEAN regional case study and the ASEAN framework for your reference. This upload in the ASEAN website. So I go to my end of my presentation. Thank you very much for your attention.
Thank you so much, Dr. Supaporn. So for the next session, I will present a brief summary of our findings from the research project, Analysis of Policies to Address Health Inequity among Low-Income Migrant Populations amidst the prolonged COVID-19 pandemic, Malaysia, Singapore, and Thailand. Okay, for the introduction, all of us, we know it's undeniable that the COVID-19 pandemic has exacerbated health disparities in vulnerable populations, including migrants. And in the last quarter of 2021, it was estimated that there were 240 million confirmed cases of COVID-19, including more than 4.9 million deaths globally. Migrants are vulnerable populations with increased risk of COVID-19 infection, severe morbidity, and mortality. They are affected by a range of factors, both direct and indirect impacts of COVID-19 over their migration journey, including pre, during, and post-migration. Throughout this crisis, healthcare providers, public sectors, and private partners have changed the way they work. However, not all of them promote an equitable approach to ensure care for vulnerable people, including migrants. Actually, this meeting is the platform of our knowledge dissemination of the research project, analysis of policies to address health inequity among low-income migrant populations amidst the prolonged COVID-19 pandemic, Malaysia, Singapore, and Thailand. The objective of this study is to address global health policy challenges of growing health inequity over the course of the pandemic, with Malaysia, Singapore, and Thailand as a case study. The aim of our study is to explore the global health policy challenges arising from health inequity during COVID-19 with the following objectives: to conduct a critical analysis of the impact of the prolonged pandemic on migrant populations and to assess global and local health system responses to COVID-19 crisis in terms of equitable allocation of resources and welfare for migrants. Actually, our target populations here were broader than just migrant workers. Rather, we focus on all low-income migrant groups. For research methodology, we perform a literature review including international and domestic publications. We also conducted in-depth interviews and focus group discussions among health and non-health stakeholders and also migrant communities. We applied the Oxford COVID-19 Government Response Tracker as a framework to assess the impacts of social, economic, and public health measures on low-income migrant populations across 3 countries. The findings from the desk review and in-depth interviews were analyzed together by familiarization, thematic analysis, and interpretation. For knowledge dissemination, so far we have conducted 4 workshops as part of this process, and we aim to engage stakeholders from health and non-health sectors working in the field of migrant health at the policy level. And this meeting will serve as our 5th workshop. At the end of our study, we explore key challenges of health inequity among migrant populations across 3 countries with similarities and differences due to our unique context. For Malaysia, we found that poor health literacy and language barriers are key challenges to accessing healthcare information. The fear of immigration arrest and deportation is substantial within migrant populations. Xenophobic sentiments and hate speech against migrants are on the rise among local communities. Immigration rates and a lack of trust in the Malaysian government are prevalent issues among migrant populations. For Singapore, migrant workers are excluded from the mainstream healthcare system and national pandemic preparedness plans. There were delays in isolating COVID-19 positive migrant workers from dormitory rooms during the acute phase of COVID-19 and increased anxiety among migrant workers. Language barriers and communication challenges are profound between migrant workers and healthcare workers and other government stakeholders. Prolonged isolation and mobility restrictions are critical, which hamper continuity of care after discharge. For Thailand, there was a lack of affordability of healthcare and difficulties in accessing funds with limited central budget allocation for non-Thai populations. There is a significant policy incoherence regarding national law enforcement and public health actions for migrants. And migrants with precarious status, especially undocumented migrants, are facing challenges in accessing health care and social welfare. So there are policy recommendations across 3 countries we need to highlight. First, it is critical to create a more inclusive health system and work on universal health coverage for migrant populations by improving access to health care and social protection. Second, governments should work together on a rights-based approach to minimize barriers to healthcare access for undocumented migrants. Third, advocacy and evidence-based communications are crucial in addressing issues of xenophobia, discrimination, and stigma among both migrants and host populations. Fourth, communications of relevant health and safety-related information should be provided in migrant-friendly languages and using mediums that would reach these populations. Fifth, mental health interventions and programs should be tailored to the needs of migrant populations, especially during emergencies and crises. And sixth, it's crucial to adopt equitable long-term policies that promote access to health care and social welfare for migrants. Migrant health policy should be based on the principles of humanitarianism and a human rights approach. That's all of my presentation. Thank you. Thank you. For the next presentation, I would like to invite Associate Professor Tharani Rongkanathan. She is our research partner from the Department of Social Medicine and Public Health, University Malaya, Malaysia. And for this session, we will go for the insights of her interesting findings with the unique context of Malaysia. Please welcome Dr. Tharani to the floor.
There's nothing here with my slides. Okay. Good morning, everyone. I'm Tharani. I'm from Malaysia, University Malaya, and I was part of the project for 2 years looking at COVID-19 and migrant workers in my country, migrant populations in my country. Just a bit of background about the non-citizens in Malaysia. So we have something like 2 million migrants in Malaysia. That's about 8% of the population. And the groups of people that we are most concerned about are actually the migrant workers, the low and semi-skilled migrant workers, and the refugee asylum seeker communities. The migrant worker communities, we have 2 groups, basically the documented and undocumented groups. The documented groups, we know it's about 1 to 2 million. Okay, the undocumented, the numbers are unclear because they're undocumented. So they might be larger than the amounts that we predict. It might be 1 to 4 million. Refugees and asylum seekers in Malaysia, the numbers are smaller. They're about 180,000, but they are also very high risk. They are coming from many countries around the world. Okay. We also have a sizable stateless and undocumented population that are very varied. Stateless and undocumented for multiple reasons. So we focus on these populations because they are vulnerable, and in this, they are vulnerable beyond COVID-19, but the vulnerability they faced is actually to do with their lack of job security, during a pandemic especially. Let me just free myself here. During a pandemic especially, they are the poorest. They are the ones who do not have job security. They are not the ones who actually get any sort of social protection. Okay, so yeah, so they face housing insecurity, food insecurity. So they are more likely to be sick. They are more likely to not go to healthcare and present late. Okay, and also they have there's a lot of pre-existing stigma. So during the pandemic, they actually first faced xenophobia and worsening threats, security threats. And of course, they have pre-existing barriers to healthcare access and a lack of trust in systems. Okay, so some of the pre-existing barriers in healthcare access in Malaysia for migrants are, I think, quite similar in different countries as well. The main barrier is actually financial access. Okay, so healthcare is very expensive. Malaysia has a mixed public-private healthcare system. The public system is subsidized for citizens, not subsidized for non-citizens, and it's something like, I would say, about twice the price. Health insurance coverage is only for documented workers and certain documented workers. Domestic workers, plantation workers do not have health insurance. Needless to say, undocumented workers do not have health insurance. Okay? Refugees and asylum seekers do not have health insurance. What they have is a discounted price for services at public health care. Okay? But also the refugees do not have a right to work in Malaysia. So they are very poor. Yeah? So healthcare is unaffordable. Okay? We also have legal barriers to access. So at public clinics, hospitals, they would check your documents. They would check your passport and work permit to see if it is valid. And actually, public, as in government healthcare facilities, are obliged to report undocumented persons coming to healthcare access. So these are major barriers. So the other barriers include language barriers and so on, which I think you can understand because we have workers and refugees, asylum seekers from multiple countries. We do not have systems of translation in our healthcare services. Thank you. Okay, so now, hello. Let me go on. So this is quite a simple, I'll just go into it very briefly. So primary care access in Malaysia, we have public and private. Migrants usually go to private because public healthcare, as I said, there's document checks, it's expensive. And then of course, it's not so responsive, there's long waiting times and so on. So they go to private healthcare. But at private healthcare, they don't have insurance coverage. Employers are not obliged to pay for healthcare. Okay, so only some do. So that's a barrier. So they might avoid care and come in late. So at hospital care, eventually they will actually go to public health care because even though it's expensive, it's cheaper than private. It's cheaper than private health care. And outcomes are usually bad. Okay, so in Malaysia, the COVID situation, right, we don't have exact numbers for the exposure for migrants in Malaysia for COVID, but what we have is from the press statements and so on. Up to February of 2022, we had something like 3.4 million cases, and of those, the clusters, about 60% of the clusters involved workplace. Okay, and of that, about 63% involved migrant workers. Okay, so that's just to give you an idea that a lot of the cases were in the migrant populations. The deaths that we had, 36,000 deaths as of October of 2022. We had a very high number of brought-in dead cases. So 1 in 5 cases were actually brought in dead. Okay, and analysis of those data, the brought-in dead cases data, a large proportion of those were non-citizens. So it was non-citizens were 4 times more likely to be brought in dead. Okay, I won't go into detail about this map. Just nicely to say to you that we had movement control orders for something like 2 years. We changed the terminology over time, so the restrictions were different. Okay, basically international borders were closed. There was restrictions on movement. Offices were closed, workplaces were closed, and so on. What is interesting for migrant workers, what affected migrant populations were actually the EMCOs. EMCOs were when there were highly localized clusters, and health officials and security would actually confine those areas. So it's a localized lockdown. Okay. So one of the major events that happened, the first was in May of 2020, 1st May 2020, we had actually raids, immigration raids following an EMCO. And the EMCO usually were areas of COVID clusters, and a lot of the COVID clusters were happening in places where low socioeconomic status, people of low socioeconomic status were living. So it was places where refugees and migrant workers were living, markets, and so on. Okay. Also, the closure of international borders. So our country was actually stopping entry into the country. So ships, boats coming in with Rohingya were actually turned back, and so on. So there were a lot of immigration activity, increased immigration activity, and the sort of sentiment was there that that foreigners were bringing in disease, and because of all these actions that were going on. And immigration raids also sort of reduced trust in the health system, because it actually followed health action. There was quarantine, there was isolation for health, for screening and so on. And then after that, the police and immigration came and there were arrests. So from then onwards, the health part was difficult. It was difficult to convince those populations to come forward. Okay, so there were a lot of economic stimulation packages. Needless to say, none of them actually targeted migrant populations directly. They were, but I would say the effect was indirect. So they would support employers and companies and businesses. Okay. Just to summarize the policies that we had. So the health policies that came out from the beginning, very early in the pandemic, January 2020, actually was very good, very positive. Ministry of Health actually gave free testing for those migrants, non-citizens who were suspected of COVID-19. So close contacts or those with symptoms who were referred for screening. So at that time, for testing, at that time it was very expensive. Services were very expensive. So there was an exemption to it. But over the pandemic, this sort of thing changed. So yes, healthcare services were still free for COVID-19, so admissions and so on. But quarantine, actually, in Malaysia, we had centralized quarantine centers, because even among the Malaysians, we could not quarantine properly. We could not isolate properly. So they had mass quarantine centers. So migrants were allowed to go in, and for a while it was free. But a year later, in January 2021, the responsibility for payment was pushed to employers. Okay, so that also caused a lot of issues because employers didn't want to pay. Okay, later on, after a lot of debate on vaccination, Malaysia actually came up and gave vaccination for free for everyone in the country, including irrespective of status. Okay, so our study, we also looked at policy. So we did desk review, extensive desk review, looking at government reports, newspaper articles, grey reports, and published articles. And we did qualitative research from multiple stakeholders to study the effects of policy on migrant communities. How did they get the information? Did they understand the information? Could they comply with the information? So we focused on main public health policies that happened in Malaysia. First one was movement restriction. Second was the use of NPIs, face masks, hand washing, physical distancing. Then we were looking at screening and testing and hospitalization. Okay, so on movement restrictions, the issue was it was actually difficult for them to comply. First of all, especially the first MCO, a lot of them lost their jobs, and it was survival mode. They had no food. They actually went out to look for sources of income or to find food. So a lot of times it was not because they didn't want to comply, they had no choice. Communication was also a problem. All the communication that we have, public communication, official communication, is in our national languages. We had a lot of communication, daily press conferences with the DG. Everything was in national languages. The international organizations and NGOs actually stepped up a lot to communicate with migrant populations. But I think you can understand how challenging that would have been, because translation was difficult. And actually at that point, government policy kept changing. The movement restrictions was very localized, sometimes to a district level. So I think the organizations couldn't keep up. Also, we have populations that are illiterate. The Rohingya population in Malaysia are illiterate. So a lot of the communications came through with the grassroots creating videos and audio messages. Okay, but it was very challenging. Okay, I talked a bit about the authorities' treatment. So they were very concerned about this. So EMCOs, as I said, it was like the localized lockdowns, and you could not leave your house. So those, after events of raids post-EMCO, migrants would actually run away. They would not cooperate. So that was actually a very bad happening. Okay, so face masks and so on was a luxury, really. I think you remember early in the pandemic, it was expensive even for us to get it. So, but in Malaysia, our public health laws were basically quite strict. You get fined if you're not wearing a mask. And if you can't pay the fine was quite hefty. It was like 1,000 ringgit. You're jailed. So they would find a mask, but it's not of good quality. It might be a cloth mask. It might be a disposable mask that's reused for weeks. So, yeah. And housing is challenging. So this is on all the populations that migrant workers, refugees, asylum seekers. They all have challenging housing issues. Migrant workers in Malaysia, very similarly to Singapore, did not have the best of facilities. Refugees stay in shared housing. So there are multiple families in maybe one apartment. So they cannot isolate. Yeah. So they do not actually comply to NPIs because they want to protect themselves. They comply to NPIs because they want to make sure they're not imprisoned or fined. Yeah. Screening and testing, as I said, there was a policy from the government to provide free testing, but that is really limited. During the pandemic, we wanted to screen populations as well. Those screenings was expensive. Employers were supposed to pay for it, but it was expensive. They also were not always cooperative because fear of arrest. The policy that pushed people for screening was actually the government, when the government wanted to reopen industry and return to work. So screening for that purposes, employers would pay for. Okay, so quarantine and hospitalization was a challenge because home quarantine was impossible. Home isolation was impossible. Those mass quarantine centers were actually very good. The problem was the check of documents, and eventually when they started charging employers for quarantine, that was not good. So NGOs were actually trying very hard to house or quarantine these people in informal facilities. The problem with hospitalization was, again, cost, but actually it's not really cost, it's lack of documentation. The entire fear of testing and so on, of accessing healthcare, was a fear of arrest. So that is the reason a lot of them presented late and probably were brought in dead. So I think today our agenda here is to actually think about how we can improve and how we can learn from the pandemic, and how, we don't want to wait for the next pandemic to actually deal with this. So I think the most important thing is actually UHC, and really a mechanism for help for all. This one, we always talk about it, but it is not practiced. Actually, there is still a lot of people who are not covered. Securitization of health. Okay, so this is something we face every day, and it's still an issue. It's still an issue where the policies are still in place, where if an undocumented person presents at public health care, they are reported. So this is actually, as a government servant, it's our responsibility. That there is a policy in place. So securitization of health is actually very, very bad. Okay, accessibility of healthcare for all, housing and working conditions. So in this area, Malaysia and Singapore shares a lot of similarities in the conditions of housing. But the progress since the pandemic on housing in Malaysia, I actually don't think there is as much as in Singapore. So that's something that we have to work towards. And health communication. So I think there is a role for government to be better in health communication and to be more inclusive in health communication. Okay, so 3 priorities I think that we should look at is social health insurance, financial risk protection. Is there a mechanism available for all populations, not just documented migrant workers? Okay, reducing xenophobia, discrimination, and stigma. I think this should be our goal at any point. Okay, and especially during a pandemic, they should not be these populations should not become the boogeyman. Multi-sectoral collaboration. So this is really important at a national level and an international level, because I think our strength is our diversity. culturally sensitive and risk communication strategies. So health information in many languages. How do we harness our resources among the region, in the region, to improve health communication? Okay. Thank you.
Thank you so much for your presentation, and it's so impressive. I think anybody will agree with me. So next, I think we will have time left for the Q&A session. If any one of you have any questions or any points to raise, please, we will have the microphone for you. And maybe from online participants, if you have any issues or questions, please inform us. Okay. No, if, okay, one, please.
Hi, good morning. My name is Stephanie, and I am from an NGO based in Singapore that serves migrant workers. Prof. Tharani, I really wanted to thank you for your presentation. There are some similarities, but also differences. I just want to pick up your point about housing, right? And how you said that in Singapore, maybe it's improving in a different way. From what I can see, though, in terms of learning lessons from the pandemic, it's still very much about pandemic control. It's not seen as, migrant health is still not seen as a right. There's no rights-based approach to understanding migrants' health and health equity. And my concern with the developments in housing, specifically for male migrant workers in purpose-built dorms, is that the goal seems to be pandemic control rather than addressing migrants' health as a rights issue. Sorry, I need some water. And the goal seems to be more about self-containment. How can we possibly ring-fence migrant workers such that if there is another pandemic, we can ring-fence them and control virus transmission? So I'm not sure if that's also the direction that it's going in Malaysia, but I guess I would caution against maybe necessarily from a CSO perspective, NGO perspective, that's not necessarily an improvement, and we are quite concerned about what that means, because then any improvements to migrant health is incidental. It's really about containment, where migrant workers are seen as potential vectors of disease, but there's no sort of concurrent consideration of other determinants that you mentioned, like food security, like health, like job security. Yeah.
Thank you. Definitely, we will not advocate for the Singapore model in housing. Malaysia has a act passed already on housing, but the implementation of it is more challenging. I think it's easier for us to get laws that work, but how in the ground and who does it and who monitors it is even more difficult. So we have safe housing, and it's more rights-based and public health-based. So, you know, what is the space that's necessary? What are the services should be there, and so on. But actually, it's the employer's responsibility to provide these kind of housing. And I think, yeah, we can't go around and find everybody. That's the problem. Yeah, we live in a bigger country and less resources to go around finding people, and maybe less motivation to do that. So, yes, so definitely will not be advocating for the Singapore model.
I would like to share, maybe not involving with your presentation, but because the experience from Thailand, Singapore, Malaysia, because the three countries, we are the destination of the migration So in ASEAN, there are the other country who is the original country from the migrant. So the context might be different. One thing that I would like to support is that implementing the USC is the key thing, even for your population also. Otherwise, some minor or some population who are not covered by the health insurance could not access to care. During the pandemic in Thailand, because fortunately that our government think that if there is someone is not safe, so everyone is not safe until everyone's safe. So we think that we have to taking care of all the people. And we learn from Singapore that when Singapore have the outbreak in the migrant community, so we have a lot of migration or of migrant workers in Thailand also. But we try to do the surveillance among this population overall Thailand. But the problem that we find that during the COVID crisis, some of them went back home. And they came back again to Thailand in the, I mean, not the, I mean the maybe the route of came back is may not the thing that we check or we can surveillance the whole migrant. So this caused the outbreak in Thailand. Second outbreak that's very big in Chakorn, which is a lot of migrants working there. So in this thing that we go to that part. We don't have the problem of the screening, testing, or even treating them in the quarantine or something like that. So we try to do because we think that everyone in Thailand should be covered by our measure also. But it's still some undocumented that maybe they have the I mean, some sensitive issue that they could not open themselves to be tested or something like that. This is still be the big problem that we have to find a solution and communicate to the other country, like the original country is also the important thing also. Thank you.
Good morning, everyone. Adrian from Malaysia. So a big thanks to all the presenters. Just two comments that is irritating. One is if governments are wondering how do we find solutions for how do we remind everyone in the polite and politically correct way that being huge is a question of where that money is flowing to, right? So it's like a pot of gold, but we don't know where it's stored. And of course, we want a whole of society approach. So who has the right to take out from that pot of gold and make sure it goes to people? Because if a migrant worker is sick, and you because of security laws and health laws, you have to force him to lose his job and deport him. The economy has to spend a lot of money to retrain people, to rehire people, and I'm sure you all. I'm also careful not to make it into another. Money-making scheme. Because every migrant worker, you can pay insurance, and then you pay levies, and then you pay fines. You know, it's not fair. So let's look at a good solution. Thanks.
Okay.
Morning, everybody. First and foremost, I'd like to thank the Thai government and the Ministry of Health for organizing this. I think this is very good. Thank you for your presentation and everything. I just wanted to add, my name is Satish. I'm from MWC, Migrant Workers Center. My colleague and my friend here from home has mentioned about housing. It is easier, I think, to contain and control in Singapore with a population of 5 million than in Thailand or in Malaysia. So I think you cannot do this. I mean, whether you talk about India or China or Myanmar. But one of the things that you hit on, it is very important, it is the role of the employer. And this is where we had a disparity in Singapore, where we had dormitories, or what we call the purpose-built dormitories. These are the big dormitories that house maybe 5,000, 10,000, 25,000 workers. So they had a group of people, you want to call it dorm operators or facility managers or whatever, who took care of the workers. So there was a system of when to go out, when not to go out, when to collect the food. But then there was a whole group, and honestly, this was the first time the Ministry of Manpower and everybody was able to figure out there was almost 1,500, I still remember this, 11 factory-converted dormitories. These are small ones. These are with 20 workers, 30 workers. And unfortunately, the bosses or the employers couldn't go to the dorms, and they were left on their own. And that was a cycle. It was a vicious cycle because they didn't know what was going to happen next. Communication was down. Food issues, or even key essentials, daily essentials like toothpaste, toothbrush, shampoo, soap. Where was it coming from and all that? So all this had an effect on the migrant worker. I mean, one of the good things that we did was we ensured that everybody got their ART test, their PCR. They were there continuously being looked after. But during the circuit breaker period that we had, and moving forward, there was a misalignment as we opened up, and as Singaporeans, we were allowed to go out. After some time, there were so many phases and stabilization periods, it became a bit, crazy. But the migrant workers were still treated like second-class citizens. Even if they wanted to go out, they had to apply for an access pass. They only could go out 4 hours a day and things like that. So I think we need to understand on a humanitarian ground, how do you want to approach this collectively, whether Malaysia, Thailand, Indonesia, Philippines, Singapore, and how do we want to educate them on health issues? Because a lot of migrant workers, I can tell you from how we deal with them, health issues are bottom of their life. A migrant worker would not want to go for the health screening, because if he goes for a health screening and he finds out he's got diabetes, cholesterol, high blood pressure, hypertension, the first thing the boss is going to do is send him back. So he will try to avoid all of this. So this is an area that we will need to continuously work together, a bit of engagement, a bit of communication, a bit of education. So we all are aligned on this. That's all I want to say. Thank you.
Thank you. Anybody have any questions? So maybe Dr. Tharani, you have any points to respond? Please.
Yeah, thank you. Satish, right? Yeah. Actually, I think our role here today is to look into the long term. The pandemic is over, but that doesn't mean another pandemic won't come about. And we had some successes and some mistakes, but actually what we have to learn is how do we go on to the future? So what is the policy going to be like during normal times, during the next pandemic? Yeah, so as you said rightly, it should be human rights based. And how would we have a safe, working, living environment for everybody? So I think also another thing that actually even everyone has said, even the Thai authorities, basically we need them. Okay, they are in our country. I mean, like the migrant workers, and the refugees, they are contributing to the economy. So that's why all these authoritarian policies came about to protect the Singaporean government, authority, and the economy, right? Basically, so the mechanism worked. The same thing, to a certain extent, they were trying to do in Malaysia as well. So how do we do this so it's a win-win for everybody? It's human rights the human rights approach, and it's fair. Safe and fair for everybody, so it's a safe working environment, safe living environment. Yeah, so this is what we need to think about. Yeah.
The male and the females. So, like we had the males who are all in the dormitories and everything, but the females, because they were like, direct, so they could go out, they could not go out, they were controlled, but so within you get what I mean. So, they are migrant workers, or you want to call them domestic helpers or whatever, but there were two sets of rules.
Right.
Yeah. So this created again another sense of, tension, and, other issues. Why is he able to go out? Why can't I go out? Why must I be restricted? Why must I take the ART or the PCR test, and why, the other person doesn't need to?
Thank you.
Thank you.
And any questions from online participants? Any questions? Oh, okay.
I'm Mao from Cambodia. Good morning, everybody. Now, I just have one question or comment on the fact that although the research finding focus mainly on COVID, but how could we, in terms of moving ahead, link to the strategy for better care of the migrant worker, etc., etc.? Because although the situation seems to be particularly related to the emergency or COVID, say, but how could we, as I said, so I'm not sure whether in the afternoon session there will be some discussion on that, but we should link to the future, the real future in a sense that just not that I'm not saying that we should forget the COVID. You said that in terms of preparedness, PPR, pandemic prevention, preparedness. Just we have to think about that. But how to look at the general health services, especially as for the service or the need of the migrant in terms of the healthcare and basic need like mental housing, etc. Thank you.
Yeah, I think for the afternoon session we will discuss both contexts, including during COVID-19 and beyond the COVID-19 situation. Yeah, I think this point will be included. Yeah. So.
Hi. Thank you. Just one comment in terms of moving forward as well. Just wanted to note, in the past couple of presentations, we've seen and really need to emphasize, if we actually are going to address health inequity and promote inclusive health systems in all of these countries, we have to be thinking from a multi-sectoral perspective. And that's something that I really, having attended many of these meetings and been a part of, lots of these discussions, if we don't involve health, labor, immigration, and so on and so forth, we won't be able to address health inequity and promote inclusive health systems. This isn't just a health problem, it's a problem of all of these different technical areas. And I think something that, we saw during COVID was the establishment of lots of technical working groups, kind of lots of coordination bodies concerning the pandemic and, and other issues. In some of the countries, these have continued, and these are incredibly important forums to engage, a multitude of stakeholders and to keep working on issues related to this. So I would just like to encourage, of course, the meeting at the national level as well of such kind of, technical working groups, migrant health working groups, and so on and so forth. We know that we've got, a few established in some of the countries here, which is fantastic. So I think, keeping the conversations going and ensuring that the right people are at these meetings and that they continue is very, very important. Thank you.
Thank you for the comment. Husoy from Singapore. That was the origin of this meeting. So amongst the partners from Singapore, Malaysia, and Thailand, we had a meeting in August for more focusing on our research project. And then that time, we actually proposed that if you really want to look at the health issue among migrant workers, you need to invite the non-health sectors, like the ROM and the IAO and the other government people. We actually invite all the people over here. So I'm really looking for the more discussion after our presentation. So yes, definitely, if you really look at the determinants of health, you need to look at the non-health sectors. Thank you for the comment.
Okay, thank you. Any questions from online attendees? Okay, yeah, I have one question for Dr. Tharani. I think during COVID-19 you have kind of multi-sectoral collaborations among the government, the grassroots, NGOs, and community organizations. I would like to know now it's like we are after the COVID-19 already, and I would like to know how these things change or not in terms of multi-sectoral collaboration in Malaysia.
Yeah, so this is the very important $100 question, right? Is it 1,000 ringgit question? Yeah, something like that. So during COVID, you had a big impetus to work together. I mean, it was not just a health issue; it's a security issue, it's an economic issue, and everyone had to work together. So the motivation was there. But now, post-pandemic, that motivation is not there anymore. Okay, the problem is the issues are no one wants to take ownership, right? If you ask MOH, they would say it's a labor issue, it's an immigration issue. Yeah, health always takes the back door until it's not. Yeah, so before this, actually, before the pandemic, MOH had very little say in health of this population. It was mostly labor and immigration. And I think, as Adrian pointed out, the money was a big issue. Financing was a big issue. So the responsibility for the Ministry of Health was not there as well. So we, in the country, but also externally, need to actually bring this back into a health problem, health issue, and involve everybody in.
Any questions? Any more questions? If no, I think it's time for a break, for the morning break. And we have about 15 minutes break, and we will come back here again at 10:40, and 10:45, sorry, yeah. And we'll see you again.
าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลัก เครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุก ความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเรา ข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย
the category and the category. So if you look at over here, but the two-thirds of the migrants are working from the unskilled and semi-skilled workers. So it's about 1/4 are the migrant population, and out of the 1/4 migrant population, about 2/3 are the low or unskilled population. But here things, in terms of the Singapore, we have a kind of quite interesting case that compared to other countries, Singapore, we only have the economic migrants. So we don't really have any kind of migrants who are unforced to move or involuntarily move to the other country. So we are only looking at the economic migrants, which means that they are voluntarily come to the Singapore to work. So I think that's kind of, there's other kind of complexity in terms of the illegal overstayed or kind of involuntary forced migrants are not case of in Singapore. I think that's the kind of one reason that in terms of the migrant policy or kind of response to any kinds of the infectious diseases or any kind of cases can be done more clearly, somehow easily, because you're only looking about the economic migrant. I think that's also going to bring some issues about this. Stephanie said we have 4 delegates from Singapore. In terms of can you really do the right-based approach? because the Singapore, we have only economic migrants, which means that the Singapore really come up with some market-based approach, not about the right-based. So we don't really have a kind of humanitarian assistance going on because they are kind of coming over here, economic region. So it's really kind of difficult to kind of bring up or kind of bring about the rights-based approach, the market-based policy. So from the two-thirds of the low-skilled or unskilled migrant workers, these are the work sectors. About 40% working in the construction, marine, shipyard, and process sectors, and then 26% working on the domestic workers, and then other one-third working on the other sectors, including services, etc. Okay, so what are the impacts of migrant workers and review of key measures implication? I'm just going to give a word about the conceptual kind of the discussion. Since we have 4 delegates from our country, they're going to give more insights on what's going on the ground. I'm here just only representing the more academic side. Obviously, I can't give any kind of voice from the ground at the grassroots. So I'm trying to make it more limited to the more academic side. However, I really hope to have a more kind of discussion later on. So this is a slide actually I'm using for my class. So suppose there's a country has a 2 subgroups. One group has about the COVID-19 prevalence about 0.12%, and the other group has about the 70% of the COVID prevalence. So I asked that which country is it? And then how do you feel if you're going to belong to the group B instead of group A? And then what happened to the group B? So just imagine yourself, then you are the group B, and then you are the group from the prevalence, the rate difference about 140 times. So group B has about 140 times more likely to have COVID-19 than group A. Then I ask the student, oh my God, what's going on? You know which country is it? It's Singapore. I think that Singapore has the most kind of, the sharp, the disparity between the local and the migrant population. I'm not talking about the overall, but the first 6 months. The first 6 months, there is a kind of sharp disparity of the local and the migrant population. You can see over here, this is the report from 2021. I think 2021, yeah, so 20, not about 21, sorry. So that compared to over here. I guess the question is, what's really going on over here? So this is the first kind of the wave, first wave of the COVID-19 here from the starting from the February 2020 to about early beginning over here. They could see that these are the dorm resident migrant population. They don't use the word migrant at the time, to use the dorm resident, but these are the local population. Clearly, you can see that the sharp. And another issue in terms of the dealing with the early beginning is that they're trying to kind of differentiate the local and then the migrant population. So they're kind of sort of, in terms of kind of working as a kind of separate the outbreak, doesn't really work in a way. So they're really kind of combining together. So what's really going on in the first wave, of the wave here? We know that, some of the kind of the factors, risk factors of the kind of, the outbreak from the migrant population. Clearly, there are some the dormitory condition, overcrowded, kind of unhygiene, etc. I think the reason that the high disparity for migrant workers are more about dealing with some unjust responses. So yes, there are cases. However, the government didn't really know how to respond to it. I think there's really kind of neglect response to the migrant workers. Because of all the kind of neglect responses to COVID-19, where about the case are really kind of highly going up. And so by the 2020, and then almost about 92% of total case rate from Singapore. And then after that, through the June to August, they did all the serological testing to the dormitory. So basically, they did all the kind of antibody testing. Found out that overall infection rate of the migrant worker dormitory is about the 56%, ranging from the 55 to 56, and then some of the dormitory go up to 74%, which means that basically one out of 2 migrant workers are getting infected with COVID-19. That's the case. So it's high. Afterwards, so this is shows overall the COVID-19 kind of the outbreaks. So here are the first wave and the second, fourth, second, third, and fourth, fifth wave over other years, about 2 years, you don't really see that kind of migrant workers over here. Kind of see this is all the local population. Why? Why we don't see any kind of the outbreaks from the migrant workers? Because they are totally locked down. So even after the first wave, so the lockdown has to be released sometime July and August. So there's going to gradual the relaxations of the old restriction. However, that kind of the release has not been applied to migrant workers. Some migrant workers need to be confined to the dormitory up until about 2 years, until June 2022. So I guess that's another issue in terms of the COVID-19 or any kind of infectious disease outbreak control. Lockdown is easy, but the more difficult part is about the exit plan. How are you going to exit the restriction, right? So clearly that's the, I was working with the government sometime during the COVID-19 lockdown period. The most concern is how are you going to make the kind of really strategic, effective exit plan. So somehow that kind of explain work for the local population, but the government and the others, we don't really know how to make the exit plan for the migrant workers who are confined to dormitory. So then it has been never discussed. Because of that, the workers has been confined for 2 years without any kind of freedom to go into the community. Obviously, you're going to see that what's really come out of it, the mental health issues. So many people got depressed because they're losing all the social contact. Basically, they're losing all the social ties. Although they get all the support from some community, meeting, worker needs to meet the people. They want to kind of hold hands, kind of drinks together. You know, kind of meeting on the online doesn't really help them kind of be a more, mental, they're not going to solve any mental health problem. So I think that's really going on. The other issue here is that from the ground, when I'm working with the health service and the MWs people, I think the most concerns after all the kind of first wave, you hear from migrant workers, not only about the health, they are more concerned about the economy, financial burden. Because they come to the country to make money to support their family, home country. So whenever you talk to workers, they're saying, oh, when can I go back to work? When can I, I guess that's really kind of comes about how you're going to negotiate the health concerns and that the main reason come to the country. So these are the major has been implemented in Singapore, and what are the impacts? Let's kind of summarize the table over here. Obviously, you can see that one of the impacts is the shortage of migrant workers. So country needs to development, but there are some shortage of migrant workers. If you want to have a slide, just email us. I think the organizer has my slide, so you could just send email to get the slide over here. And then the lockdown time, all the kind of confinements going on. And then we started the circuit breaker from the April, the totally kind of whole lockdown from the April to June 2020. Clearly, workers are kind of prohibited, to work. That's kind of really major impact, right? Because once again, the lockdown, the thing is that they're gonna call from the family members. Oh, where's my money? I need to have money to support my family. Need to send the kids. I mean. Even though I'm working in the public sectors, I think the main goal for the country is not about the health. We work for family. I mean, even me, if you're going to ask anyone about your life, what is your life goal, they're going to say that to be healthy. Right? I think the health becomes a more instrumental kind of, way using the tool to pursue their fulfill of their life. So workers for them is about they wanted to come here to make money and go back to their life, right? I guess something really impacts going on, but in terms of the health interest, they wanted to kind of lock down to prevent the diseases or kind of prevent the spreading the diseases. I think that's kind of really sort of how they're going to really negotiate it, right? So clearly, the another one is about the prolonged restrictions, but about almost 2 years. And obviously, it causes high level of anxiety and poor mental health. This is a really big problem, right? So there's even like the discussions about there's some debates about if you really we're going to have a kind of when you're working on the outbreak, you're working on the two sides. One is about decreasing the diseases, but if you're going to really kind of pushing too much about only looking at the diseases of the control, you're going to see more about the risings of despair, rising of despair, right? So there are people who really kind of feel despair and they're unstable. And then government had some kind of made a policy to waive of the levy and there's some provisions of rebate. Obviously, these all can help the sort of kind of sustain the economy for the company, but that actually can be the privilege or levy or compensation has never been translated to the migrant workers. Also, during the lockdown, afterwards, the government kind of provided some payments of basic salary. However, the basic salary is not really enough for workers. They need to work harder. They need to work more overtime to make it more need. Right? So this is the kind of really workers face high levels of financial insecurity and job precarity toward the lockdown. And then, yes, in terms of the public measures, in terms of coverage and medicine was pretty good. I think the government, what really government has done good is the COVID-19 in terms of the medical services. So, yes, the first wave, about 6 months, had a difficulty. However, the government learned from the first wave, so they quickly kind of mobilized all the kind of medical facility, so provide about 100% of testing, vaccination, free of charge. And then later on, the government launched the mobile app, so to facilitate the healthcare access. So workers need to report the temperature through the online app, but they could actually using the app to access the health care. So whenever they're saying, hey, what's going on, I had some fever, I had some COVID symptom, so they immediately, the MOM, they immediately respond to the app to provide the care. And then the also government to deploy the mobile medical team to the dormitory, so they try to kind of create easy access to all the health care. I think in terms of the COVID response in terms of healthcare services, healthcare access, probably one of the best countries in the world for the migrant population. Again, the reason is that we have a really definite population, economic migrant population. We don't really have any illegal kind of overstayed and then undocumented, etc. refugees. And then the public measures are the implementations of all the mandatory testing and then ART, which is good, but somehow too much things going on. So the worker needs to kind of report the ART every 2 weeks. Gets really kind of burden. Somehow then later on, again, to 2 years of the lockdown, kind of, every 2 weeks about the testing gives a really, put it really in the corner, worry what's going on. They certainly feel they have too much control in a way. And later on, so we kind of hear about some of the cases about the mental health problems, depression, and then somebody going to commit the suicide attempt is going on. So the government launched the multi-sectoral mental health task force, the Project Dawn. So all the work, our delegates from Singapore, they also work in the Project Dawn. So Project Dawn was the kind of sort of really multi-sectoral the collaboration. So coming from the MOM, MOH, and the psychologists from the IMH, the psychiatric hospital, and then NGO from the health service, and we all together. So we make a table so how we're going to work for the workers in mental health. And then we also launched the 24-hour crisis hotline. So this is the multi-language support served by health service. We have people from health service here, so he could give more about it. So these are kind of really working on the moving towards from the infectious disease control to the mental health support. Another kind of sort of measure we've seen is by the employers, right? They give us some too much kind of, sometimes they go beyond the government kind of control that had a kind of their own way to kind of give us some impositions and they keep things going on, right? So summary, what has been done and what needs to be done. Obviously, what has been done first was about the establish the multi-sectoral collaboration. But yet, the one needs to be done is that the early stage, all response was not really good. So there was some delay of the response to the migrant population, migrant workers. But clearly, moving forward to the COVID-19, the government now building up the national plan for the pandemic preparedness, including migrant population, as a kind of inclusive way. And then the provisions of the free testing, treatment, vaccination, which is really good. And then the access to telemedicine by the mobile app. Yet, in terms of the healthcare access, medical care access is really good. However, what's really missing for migrant workers about the social safety net. that was not existing. Obviously, if you really look at the social safety net, you also need to kind of bring up to the rights-based approach, but we haven't really seen that kind of social safety net. So I guess that's the kind of way to looking at the whenever you're working on the infectious disease control or any kind of public health crisis, government from the government perspective, one of the goals is to control the diseases, but the other is the government perspective to protect the citizens in terms of their well-being. However, we don't really see any kinds of the social protections or financial protection to protect their well-being from migrant workers. They only focus on the disease control. So I guess that's the kind of one thing we look at. What is the goal of the public health? Our goal is the public health to kind of control diseases, or our goal is to kind of promoting health from the population, right? I think that's the kind of we're debating over there. And the dissemination of information through the online application or online, but clearly what really needs to be done is that there's the lacking of the social support, right? So they're losing really kind of transnational community ties due to the kind of prolonged restriction, right? I think they're really kind of they're missing their friends and colleagues from the community, right? And then so the implementation of the initiative to address the mental health issues of workers, I think what really needs to be done, what's really missing is about the lack of focus on whole of system vulnerability, right? The mental health kind of the intervention of migrant workers only looking at the screening and detection. Okay, got it. But they're only looking at the determinants of mental health, and then also the what are the kind of holistic way to kind of include in the mental health. So they're only looking, okay, who get the problem, right? How are you going to report them? But there wasn't any kinds of moving beyond the screening or detection. The other thing is the mental health things currently going on. Well, another missing point is the evaluation. There isn't much about the evaluating the mental health the intervention for migrant workers. So I got about 5 minutes now. So we also did the interview with all the stakeholders. This is the part of the WHO project. So I mean, these are kind of the findings are kind of overlapping, so I could really kind of skip over here. Is that ASEAN we kind of using the WHO health system building block to see, we're trying to kind of using the framework to see how our data kind of fit into the framework over here. This the HSBB has a 6 blocks: governance, information, financing, service delivery, and human resources and technology. So see how each block goes on. So first, the health service delivery. Clearly, there are services available for the healthcare accesses and the COVID-19, the things going on. I think what's really missing is about the more cultural competency. So even though there are healthcare services available for the COVID-19 prevention control, but clearly there's a lack of the cultural the sensitivity or competencies at one point. In terms of the health workforces, I think maybe the lack of the cultural insensitivity, lack of competency coming from the lack of structured training for the healthcare professionals. There isn't any kind of protocol for healthcare professionals how to work with the migrant workers. I think that's one of the issues. And health information system are one of the issues coming from the health information is about the lack of trust. So only the epidemic, the workers really can depend on the more informal sources from their friends and their families. So there wasn't much of the health information coming from the more reliable, trusted source. So that's another thing about the spreading misinformation. So then in terms of health information, we need to really work with the more trust issue. And then access to medical products, vaccine and technology is great. Singapore did a best job for all the healthcare access to medical product vaccines, so there's no problem with it. Financing, again, there is also inadequate financial assistance for those people. I think what's really missing from the HSB, the health system block, is about this one, the leadership governance. We haven't really, even after the 2 years, we haven't really seen the development or the value of the leadership from the migrant community. I think that's really one. We need to look at the more future pandemic preparedness in terms of the inclusions of the migrant community, and then the governance and accountability. Who's going to be accountable whenever you do any kind of the work? So moving forward to the migrant worker policy consideration, I'm moving to the end. So these are the policy affecting healthcare access in Singapore. So there is just overall, the summary is that, this is kind of really interesting discussion for today is that what's the really the minimum, what's the threshold we need to give it all the health care, right? So obviously, what are the kind of decency, what are the we can look at? So it's really hard to say where is the threshold or the health care access. Obviously, there are some basics applied, but the procedures are difficult, and they many are not covered by the policy. Mainly the EFMA, the Employment of the Foreign Manpower Act, is kind of regulating all the management of the migrant workers. What's really missing? Education. There's a lack of education for the migrant workers. Again, we talked about all the ground people saying that even though you have some good policy, migrant workers need to take in. All right, so let's say that we're going to provide education. Whether there's an interest about taking education for migrant workers, education is totally missing. And then in terms of labor protection, too much tie onto the employer. Again, in terms, let's say the dormitory condition, who's going to be accountable? Can you just put the accountability to the dormitory association or company? I don't think so. I guess the ultimate accountability should go to government because they had some policy, right? These are the dormitory, the operator or the company are the implementer or executor, right? So I think that's really looking at who's going to be accountable for the other labor protection, even like the living conditions. And health protections are good, but mostly focus on the more creative, not about the preventive. So we don't really have any preventive intervention for the migrant workers and then the mental health services. And then obviously there's no any policies specific on the social assistance, social welfare. After COVID-19, lesson learned, Singapore is moving forward. So there are policy discussions going on in terms of how to improve the living conditions of the dormitory. This is a major concern for us. So there are many policy documents you can find from how these are new regulations for the living conditions. And then the government, the MOM, they implemented the new primary care sector plan. So they're going to make the zones over here so they can make easy access to the primary care. So this is really another advance, another step providing primary care for all migrant workers. Yet, utilization is a question. I don't know how, and the migrant workers will utilize all the primary sectors. But in terms of policy, it's a good step, right? So I'm gonna end. Okay, time's out. Two slides. I'm gonna end with we came here for discussion about health equity. So this is the Margaret Whitehead. She worked in the early 90s, come up with this definition of health equity. So she defines health equity as the difference in health that are unnecessary, avoidable, unfair, and unjust. If there's any difference coming from the unnecessary, avoidable, unfair, and just are the health equity issue. And she also pointed out the equal access to available care for the equal need. She's not looking, the health equity is not about looking at outcomes, but the needs. So we need to know what are the needs the migrant workers have. I think that's the one step for the health equity. Based on the health equity, US CDC created another framework. This is the health equity framework from the US CDC. One thing that I would want to, the reason that I have this one is that this is how they define the public system. Public system is not only including all health sectors, they're including education, art, economic and environmental agency. So this actually coming broad about all the rights-based approach and determinant health. If you really look at the public care system for migrant workers, you also need to looking at the education, art, and the living condition, etc. So these are steps for how you're going to achieve health equity. The first step is the assess and monitor. I don't think any country take the first step. Even Singapore, we don't have any system for assessment and monitoring. If you don't monitor, you never get any make some good policy making development. But I don't see any monitoring system in anywhere in the Asian country to looking at the health disparity and health equity for migrant workers. We need to develop the monitoring system. We need to get the data so that we could evaluate whether we actually are going for the right direction or not. Okay, thank you.
Thank you so much, Dr. Husso, for your invaluable insights. Now we will, I think we have time limitation, so we will go for the next presentation. And we will skip the Q&A. And after Dr. Panwit's presentation, we will go for the Q&A session. Okay, for the next session, we will go for the presentation as part of the report on a joint mission to review health system capacity in addressing migrant health needs in Thailand. This report was conducted by the Ministry of Public Health of Thailand in collaboration with WHO and served as a pilot project to develop the refugee and migrant health country assessment tool to explore progress and challenges in advancing UHC for migrants in Thailand. This session will be presented by Dr. Panwit Kamchonchai from the Faculty of Medicine, Ramathibodi Hospital, Mahidol University, Thailand, and he is one of the lead researchers of this project. Please welcome Dr. Panwit. Please.
Hello everyone, I'm Dr. Panwit Kamchonchai from the Faculty of Medicine, Ramathibodi Hospital, Mahidol University. Formerly, I served as a lecturer in health system science and also work as a health policy and system researcher. My work mostly focused on strengthening health systems with a particular emphasis on effective coverage. Today, I'm going to present the process and the key findings of our report entitled Health Systems for Migrant, a joint mission to review health system capacity in addressing migrant health needs in Thailand. First of all, I would like to thank to the session organizers, particularly the Health System Research Institute, HSRI, for the kind invitation to share our work with you. My presentation will be brief, as the findings have already been mentioned in a talk by organizer. I will focus on our country review process and the recommendations we have formulated. However, if you can find the information about the demographic, socio-economic and migration factors in Thailand and also regulation frameworks in the review report. Additionally, I would like to declare that I was only a small member of joint review team. Today, I have the honor of presenting on behalf of this team, which was a collaborative effort involving the Ministry of Public Health, the World Health Organization, the International Organization of Migration or IOM, the Health System Research Institute of Thailand, and many other partners. Our review was conducted following the Omicron wave of COVID-19 pandemic around October 2022, and the findings were subsequently presented to the Thai Ministry already. So here are three key objectives of our country review. The first objective was centered around the collaboration. We are committed to convening both international partners, stakeholders, and diverse domestic stakeholders. Our goal is to collectively identify the current strengths of our health system, pinpoint the challenges we face, and uncover opportunities that will allow us to advance health services for migrant population. The second one is we work to align and synergize support our international partners, ensuring that our efforts are in concert with Thailand's strategic plans for migration health. Finally, we were committed to contributing to the global dialogue by showcasing Thailand's strategies and operational tactics in expanding universal health coverage to migrants, which will also serve to refine country assessment tools in care system for migrants. This slide provides an overview of our country review process. Initially, the WHO and HSRI established a secretariat group. Then HSRI, together with the Faculty of Medicine, Ramatibadi Hospital, conducted a desk review, which we collected all pieces of related literature, evidence including published articles on scientific database, the research reports, the conference abstracts, and the policy papers. Following this, the WHO Secretariat, in collaboration with the Ministry of Public Health of Thailand, formulated the agenda and identified key stakeholders for engagement. This was based on the findings of the desk review process and the critical questions that needed to be addressed. The joint review team then conducted stakeholder meetings and key informant interviews. Finally, the team synthesized the key findings and presented the policy recommendations to the Ministry of Public Health and proceeded to the draft of the report. If you go through our review report, you will find that we were not focused on only healthcare or public health functions during COVID-19 pandemic, but we aim to assess healthcare for addressing migrant health needs comprehensively. Our assessment encompasses several technical areas, including health system policy and governance, health financing for migrants, health service delivery, and health information systems. However, beyond these four core areas, the COVID-19 pandemic has significantly increased awareness of essential public health functions and responses. Consequently, we included two critical areas. One is public health response and one is risk communication. So the assessment tool we utilize for this country assessment is the part of a more comprehensive toolkit designed to support refugee and migrant health developed by the WHO Health and Migration Program. This toolkit is available on the WHO website, but for immediately access, you can simply scan the QR code displayed here. Okay, everyone is scanning the QR code, and you can search Google later. So, as I mentioned earlier, our review encompassed meeting with a diverse range of stakeholders throughout Thailand. For matters concerning financing, governance, and information systems, the data collection was mostly conducted in the Bangkok area. However, when it came to assessing health services, we extended our reach to Samut Sakhon province, known for its extensive fish markets and factories. Samut Sakhon is a hub for migrant worker operation. Additionally, we conducted assessment in Tak province, located at the border between Myanmar and the northern of Thailand. Also, public health response and risk communication were assessed at all sites. Here are the photos of our site visits across the countries. Our findings highlight Thailand's strengths in migrant health care. First, universal health coverage initiatives have introduced inclusive state policies since 2002 with strong disease control for all population, including migrants. The robust healthcare financing throughout the Social Security Scheme and migrant-specific insurance supports innovation both in hospital-based care and community-based care. Next, effective service delivery ensures the quality healthcare is accessible to all, backed by the public sector and also the NGOs and dedicated volunteers. Advanced Health Information System, Thailand has an effort to develop utilizing unique IDs and also biometrics, enhancing data management across the different systems. Comprehensive public health response ensure rights to health and education across nationalities and effective border health initiatives. However, our reviews identify key challenges in Thailand healthcare system for migrants. First, there is a policy incoherence. Migrants' policies are often fragile and lack a central coordinating body despite within the Ministry of Public Health. There are health insurance uptake gaps in Thailand also. Complex administration and high costs discourage migrants from registering themselves for volunteer health insurance. Services for migrant health are underutilization in some areas. Migrants face obstacles in accessing health service, especially within the urban primary health care. which not always meeting their needs. Data management issues, there are some barriers in the context of Thailand. Data of migrants is inconsistent. There is no unified system, especially for those undocumented. Public health response and limitation. There are some public health response limitations. There is insufficient funding for undocumented migrants and hurdles in planning effective health communication. So, in addressing migrant health, our policy recommendations are structured to span short-term action to long-term goals. In the short terms, we must focus on immediate interventions, strengthen the coordination, especially within the Ministry of Public Health, to create more a unified approach. The second one is intensify the marketing and monitoring of migrant health insurance to increase the voluntary uptake and compliance. Employ data-driven strategies to enable agile and flexible policy making that can respond to the ever-changing landscape of migrant health needs. For our midterm strategies, we aim to build upon our immediate actions. First, formulate coherent strategies that further universal health coverage for migrants, ensuring no one left behind. Harness the power of digital technologies to improve the sharing of information, which is crucial for comprehensive healthcare provision. Enhance the roles and recognition of migrant health workers. And in Thailand, we also have migrant health volunteers. So we need to acknowledge their vital contribution, especially during the era of crisis. Lastly, our long-term goals are ambitious but necessary to do for the sustainable change. First, systematize the inclusion of migrants in public health planning for the long term, making it standard practice rather than an afterthought. Second, work towards greater policy coherence and international coordination, leveraging global best practice and resource. Last one, aim to expand health programs such as the vaccine EPI to reach undocumented migrants, ensuring that vulnerable populations receive necessary healthcare services. So, as I'm going to finish my presentation, I would like to highlight three important ideas as a take-home message for our further discussion. First, looking closely at our country health system to see how it serves migrant health needs, like we did during our country review process, is a good move. It helps us make healthcare fair for the migrants. Second, it's quite difficult to make sure that our health system is equitable, works well, and is of high quality. But the crisis, COVID-19 crisis, shows us that our biggest challenge is to keep our health system working well and be equitable for everyone, even in the tough times. So, like Professor Tharani has mentioned, what did we learn during the crisis, and how can we make the system more resilient for the future, for all and for migrants? And the most importantly, by looking at our own healthcare for migrants, we should ask, how can we learn from what other countries do well and not so well? Can we use the same ways of checking so-called the same assessment tools or the same process to investigate how good our healthcare is and share what we find? This way we can make healthcare better for migrants together, especially in our region that we share some similarities across the countries, such as our cultural context. Now, as I would like to open up for discussion, I invite you to think more about this last point. Sadly, I have to say sorry because I can stay for the next part of session after the lunch, but I know your conversation will be great, and I look forward to hearing about what you discussed. Thank you for letting me sharing with you today. Thank you.
Thank you so much, Dr. Panuit, for your impressive presentation. So next, I will open the floor for questions. But actually, I have one question regarding this current presentation. Regarding your presentation, we can see that there are international reviewers to join the review. So do you think it is a good point to include international colleagues to critically review and analyze the findings of this work with our Thailand context? Do you think it's a good point?
So let me respond to your question first. Yes, as I have mentioned, our joint review team comprises of international partners and agencies from WHO, IOM, and also domestic country experts in financial and health system. I think first we utilize the strength of these two parties. As a Thai people, as a Thai academia, we know our own context, we know our insight, we know our own culture context, political context. We have an experience in our own system. But sometimes this familiarity causes bias. So we don't know how can we identify the gap within our system. Second, the international partners or international agencies often have robust methodologies or robust key indicators to be assessed. But the international agencies are lack of insight. So we put these strengths of two parties together, the robust methodology, the critical indicators to be assessed, and the good insight from Thai team. So we formulate a joint review from these two strengths.
Okay, thank you. And before we have a break, we have one question from Ms. Jennifer E. De La Rosa. She's the ASEAN Secretariat. And she said that as she is an observate with her role as an observation for migrant workers, she thinks that migrant workers' health in a destination country is also related to the recruitment process they go through, including agreements and contracts. Ethical recruitment is also a crucial concern and advocacy, which calls for cross-sectoral approach too. So yeah. So next, if you have any points to add or any, okay, please.
Good morning, everyone. Adrian from Malaysia. Sorry for hogging the mic. I've been part of the ASEAN Forum on Migrant Labour for quite a number of years, and in the discussions leading to the different outputs, right? I had a sense that some of the governments are, and sorry for using the term, anti-family. Okay, so they want the migrant to come, but keep the family out. I won't mention which country, but I think you can guess by now. So when I kind of try to understand, okay, you want the worker to come, but not the family, right? Children come, spouse don't come. So then the response was, oh, if the spouse come and the children come, they become a burden to society. They become a burden on healthcare. They become a burden on education. So for me, how to undo this philosophy or thinking mindset that, you know, people are human. When you separate families in a very artificial way, there is consequences. But at the same time, allow the expatriate, right? The expatriate from different parts of the world to enjoy a different set of benefit. So my point is on non-discrimination. I think there's certain natural things that we can't avoid. And thinking that we can avoid, what happens is migrant workers find their creative way to solve problems. So if you say a migrant worker can't bring the spouse, and if the wife comes, where will she get reproductive health care? If Malaysia, for example, is open, if they say that pregnancy will cause you to lose your job, and if the migrant woman gets pregnant, they will go to very dangerous healthcare access. So I think there are consequences when we try to put artificial barriers. Yeah, thank you.
Okay, maybe Dr. Huso, you have any point to add?
Yes, thank you for the comment. That's why we are kind of emphasizing the difference in terms of the right-based approach and the market-based approach. So obviously Singapore takes a market-based approach, which means that, okay, I have a job for you. If you want to kind of come here to work voluntarily, but there's no any kind of other kind of benefit for you to bring the older family, you could come. So I think that's how the Singapore kind of really do the migrant policy. That's why I'm saying that once you're coming up here, then you talk about, okay, I come here, but somehow I fall in love, had to start a family. then I had a more kind of, so what are my kind of decency, what are my dignity for as a human being while I'm contribute to the country development? Why cannot be entitled to have other human rights, just like the other local resident? I think that's the kind of main issue. But I have no specific answer to it, but I guess the solution needs to be to more, rather than kind of, more to be more policy, kind of more ethical level first, conceptually. Otherwise, if you're really kind of going for the individual cases, it will not go to the policy. You know what I'm saying? So, I mean, that's a really important point, but more of a philosophical discussion. Then, can you really moving forward to more right-based approach to where the country really more look at the like a market base? It's hard. Even that direction we are looking for, I personally don't see that will be coming under the bound from the Singapore. Yeah, unfortunately.
Thank you for your response. Okay, please. Okay. Chair, sorry. Please.
Thank you for that. I would just like to add on, because in Singapore, what Adrian raised is a very valid point. In Singapore, we tend to see the migrant workers, we classify them based on their skills. So essentially, we need the labor they provide, but we don't want them to be a permanent fixture of our country. So we only want to derive the benefits, but we don't want them to establish their roots in the receiving country, and we treat them as transient. That's why a lot of our policies are tied to this. We don't want them to remain in the country, so our health policies, our labor policies, they're all tailored towards this transience of the workers. And even for the female migrant workers themselves, they are less protected compared to the male non-domestic migrant workers in our country. For the male migrant workers, they're covered under the Employment Act, the EFMA, but for the female domestic workers, they are not even covered under the Act, which prescribes minimum working standards, wages. So the female domestic workers are basically left out of the system as well. They're not as protected. So when we think about rights, when we think about how we should look after migrant workers, we need to recognize that ultimately our governments, they do design policies based on just the economic benefits. We need to look beyond that, because these migrant workers are an important part of our economy. So Singapore is reliant on foreign labor. Like, we need the low-wage migrant workers in our country for our economic success. They build our homes, our schools, they build everything, they contribute to our GDP. But then we fail to take account for the social needs, the protections that migrant workers need, and we only want to just derive the benefits. So I think when we discuss later, we do need to recognize that it's important to adopt a humanitarian rights approach. We don't have to, Singapore's perspective, also be very critical about Singapore's labor policy. We, in a sense, we want to only focus, we take a very nationalistic approach. So we value citizens, we value residents above migrant workers or foreigners in general. But in order for us to really address the fundamental barriers, the structural issues that hinder migrant workers from leading healthy lives and contribute productively to a country, we also need to recognize that we do have to address the structural barriers, the policies that breed these inequalities. The inequalities, the health inequities, the barriers don't just appear out of nowhere. They come as a product of the policies that we adopt. So we do need to look at how equitable these policies are and to tackle the fundamental sources that lead to crowded housing, that lead to barriers to healthcare. So I think it's across the countries. We also need to prioritize this. Thank you.
I don't know whether I can say in public, in this case, there are some exceptions. There are some opportunity for the social mobility, which means that sometimes migrant workers come, they could apply for the higher visa status. As passed, then they are able to bring their family in over here. But I don't want that kind of sort of exceptional case as a policy, as a kind of standard. But be careful. The reason that I'm saying there are exceptional cases is this one. sometimes you're looking at yes, the contributions, kind of, the claim based on the contribution. I contribute to the country, therefore I'm entitled to the any kind of right. Sometimes it's kind of conflicting each other. Because you can't really use the contribution as a kind of basis. Because, then what if people don't contribute to it? Right? Human rights based are beyond the contribution. So you can't really use the contribution as a kind of human rights approach. However, I think that practically, I was thinking, one of the way for human rights, like the market-based approach, like Singapore, is to open up the more social mobility. Right? Maybe you could have a more opportunity given to them so they could have a more social mobility moving up to the next visa. Then you don't really kind of, deal with any kind of contributions or human rights approach, right? So maybe why don't you kind of have a more kind of higher or better opportunity for people to stay here? Then if they wanted to stay in Singapore, they'll have an opportunity to apply for the next visa so they could bring in a family. But that's more looking at the policy and market-based approach. Yet we could look at the more human rights.
Okay, thank you. So okay. PRE. Okay.
Thank you. So my intention to provide feedback now is not going to respond on the issue that you discussed, but like to supplement what Dr. Panuvit have mentioned about the review, joint country review in Thailand. So first of all, I'd like to emphasize that WHO 2 is something that any country would like to review should adapt to their country context. It's not something to impose that countries should follow exactly what we have set out in the 2. So that's what we have applied in Thailand, the same thing. So if you look at the 2, you have to really adapt to your context and design your methodology based on your country context. Otherwise, it's going to be like you won't really benefit much from the review because you will go one by one. And secondly, the reason I like to echo what Dr. Panuvit mentioned, the reason why we design for joint review is that the joint review is not just between the international expert and national expert, but it also country ownership. So this is 3 parties together. The Ministry of Public Health take ownerships. We are here not to score them. We are here not to verify or validate their status to certify whether they achieve this and that. We are here to support country to identify ways to improve their situation. So that is a key that we are coming into the country to help them. So the selection of the expert is very critical. But the most important part that I like to highlight, and the Mahidol University play a very important role, is they conduct the desk review before. This to help international experts also to familiarize themselves with the country. So the role of international experts to bringing their international experience is important to reflect to the country. But they also have to work very hard before they arrive the countries. So if they don't do that, when they are in the country for 5 days of review, so they themselves will be frustrating themselves and would not be able to contribute much. So this is a critical point as well that we have employed and emphasized with all international experts that before you are coming to the country, you have to really at least read the desk review report. And WHO took Thailand as a lesson learned because we conduct the same exercise in several countries, and we learned that desk review in Thailand proved that the papers and the document had helped the expert to deep dive or dissect into the issue when they went to the field. So that is one thing. And the other things I like to mention is that the secretariat team is very important because together with the external reviews comprising of Thai and international experts, we also benefit from having the Thai health officials who are technical themselves, and also the translators together in each team. So these people are helping to verify the information because people coming from the academics, universities, and went to the field hearing something on first hand, it might be difficult for them to understand. So having the health officials providing them information is also helpful. So that's all I would like to share based on our lesson learned with the country review in Thailand. Thank you.
Okay, thank you. So I have seen someone. Okay.
Hi, thank you very much for the presentations of the two speakers. I would like to seek more clarification on a very critical challenge that relates to undocumented migrant workers. Dr. Panuwich has mentioned that it is indeed a challenge that the lack of unified data system for undocumented migrants is challenging. It's not just in Thailand, but also in many other countries. Most of the undocumented migrants have difficulty accessing to health services and other social services. So I would like to know from Dr. Panuwich, what is the next step in terms of having a unified data system? What can we do more on this? And then for our speaker from Singapore, what was your experience in terms of undocumented migrants having access to services? Because this looks into equity. And it would be great to understand more on how you could provide more recommendations on that so that many other member states or governments can understand and put this into practice in their policy making. Thank you. And also regularizing them. Thank you.
Okay, Dr. Panuwich, please.
Yeah. Okay. May I respond to the question first? According to the experience of Thailand, for Thai people, for Thai nationalities, we use 13 digits ID card to identify yourself at the hospital, at the health facilities. But for the migrants worker, if they are documented migrants, they also have their own digits. But for undocumented migrants, we have several efforts to increase their accessibility to healthcare. For I'm not sure, like some professor has mentioned before, we separate the law regulation and healthcare apart. We guarantee that they won't be arrested during their health, taking care of themselves in healthcare. That is the second thing is we aim to actually we currently use the bioinformatics, the biometrics, the fingerprint, the iris, the facial scanning to identify not only for migrants but also for Thai people. So we don't need to register to get a digits or to get a card or to get something prove your nationalities. So we use the biometrics. That's two effort, the big two effort.
Okay, thank you. So next, Dr. Huso for undocumented migrants in Singapore.
Thank you for asking question to person from the country where there's no undocumented migrant. Okay, based on my experience in other countries like Hong Kong and in Malaysia, I think here's what I'm thinking. Obviously, to work with the undocumented migrant workers, the international organization is critical to help them. So you need to, the international organization need to work with the government to provide health care. So the reason that I'm saying is that whenever a country make a policy, what's the boundary of it? What's the kind of policy boundary? Usually the government make the boundary as a nation. This is my state, but this is my nation. With that cases, that sometimes the undocumented migrant workers will be outside of their nation. However, if you're going to put the boundary, the place of the human rights and health care will be a global or regional, then you can actually bring in all the undocumented migrant workers in the discussions of the regional health or global health governance. I think that's why the international organization is really critical in their cases. I guess another cases that I was looking at, sometimes when you really talk about the right space or any kind of the health equity, sometimes we kind of sort of overlook the importance of the agency, the community people itself, right? So even that undocumented migrant workers, refugees, they do have their own power, they have their own kind of assets to bring it. So maybe another way to looking at that, yes, we need to work. So you need to kind of work out of the more kind of state level, state-focused kind of governance, look at the international organization and the community people, even like one like there's some kind of community scheme, the insurance, they look at the kind of community people get together, can make some insurance, etc. So I think there's a good way to doing it, but clearly, I think the international will become more clear. The reason that I'm saying is that what are the kind of the place of the all the policy making, right? So yet because of that, Singapore we don't see any kind of engagement from the international organization because we don't need it, right? Because we don't need ILO, we don't need IOM. That's why, because we have no undocumented. That's the reason we don't. You saw Singapore people, how come we don't work in the international government? Says there's no reason. But however, you go to the other country, clearly, international work is important, right? Because we are looking at the people who need more health care beyond the border, beyond the border of the state, right? Yeah, that's my thought.
Okay, Aisha, have more points.
Thank you. Sorry, I just add on and address the question. So, in the case of Singapore, labor migration is tightly. Sorry. So, in the sense, when we take in low-skilled migrant workers, we have different tiers of, I would say, permits or work passes given. For the higher-skilled workers, they are given employment passes, which come with higher salaries, so they do have they do have a recommended salary. But then for the lower skilled workers, the migrant workers coming from our regional countries, we give them work permits. The passes are called work permits, and essentially these work permits are tied to sponsorship by the employer. So the employer essentially has to sponsor the worker to come and work and live in Singapore. So without this work permit, the worker is not allowed to stay in Singapore. And this gives the employers the absolute power over their workers because the employer can cancel the work permits at any time and repatriate these workers back. So going back to undocumented workers, so essentially Singapore does not have undocumented workers because labor migration is tightly controlled. But that being said, while it makes it easier for migrant workers because all of them are documented to access healthcare, there are barriers to healthcare that migrant workers face. Firstly, before COVID-19, now there are healthcare reforms that the Singapore government has put in place to make healthcare more affordable and accessible to workers. But before COVID-19, they were still excluded from subsidized healthcare. And there were other barriers, such as employer gatekeeping. Because of the way that employers are given absolute power over the workers because of this sponsorship system, which is still actually, the sponsorship system was adapted from the Gulf cooperation countries in the Middle East, is known as kafala. So basically what it means is that for migrant workers to access healthcare, they can go to a clinic, but then they would have to pay a lot of money. And if they do need specialized care, for instance, for a migrant worker with complex medical issues who needs to get admitted to the hospital or who needs specialist outpatient care, he still needs to obtain permission from the employer in the form of a letter of guarantee if he needs to get admitted. If an employer refuses to give a letter of guarantee, he cannot seek treatment. So there are still barriers. I mean, documentation does make it easier for the worker to access healthcare, get registered, go to a clinic, but there are still other forms of barriers in Singapore that we do need to work towards to make sure that healthcare is accessible and affordable. Thank you.
Okay. Any questions? Okay.
Yes. Thank you so much. And I just also would like to ask the question about the to Singapore as well, because I think in the same case in Thailand too, but Singapore also, Singapore and Malaysia, a lot of your presentation mentioned about the deployment of the technologies, especially like contact tracing and surveillance and other things. So like a lot of migrants, we learned that migrants from the presentation, migrant workers can report their cases, report their cases through the application and those kind of things. So how about what kind of education, like how do you make sure that the migrant workers able to use the application, how, especially domestic migrant workers, considering our construction or even the factory, how you make sure the employer to whom the responsibility bear for those digital literacy and other things, This is my question. And another one is about I think maybe it's not just about question, maybe comment, because with the COVID-19, we see that a lot of, during the COVID-19, a lot of coordination and a lot of cooperation take place, especially at the cross-border. We call it like the migrant center, like post-arrival or pre-departure orientation, cross-border center. They having, we see a lot of, during the pandemic, we see a lot of Ministry of Health, Immigration, Social Welfare, so a lot of coordination mechanism took place. Also like the CSO and every NGO, and they really involve it. But on the one hand, when we went and do the how those somebody already addressed about the sustainability of such program already. But on the one hand, when we try to talk with the migrant, those visit those centers, there is some. We also feel that the coordination have a lot of issue. Issue to talk about. The first one is about government to government, like mandate and other the conflict of the, not conflict in terms of the authority. There is no, they need to improve. And then another one is we also would like to CSO and government, and they see that CSO are more the governments, they see that CSO are not really complement, rather than being complementary, they are more criticizing, and they try to make the government job as their job. This is what we learned from the Myanmar-Thailand border. And then also another issue is when we talk with the employer also feel that, government should take responsibility when they are pushing all the responsibility for us, educating and bearing the coverage for the migrant worker. And there is another party involved is about the recruitment agency. Recruitment agency are also talking about the government are asked to educate and, to migrant worker. And so there are some kind of, putting burden on each other things are going in place when it comes to that kind of healthcare access or migrant worker thing. So it didn't just, it's not comment or it's not really suggestion or thing. I just flagging the situation, and is there any comment or whatever going on with this situation? Thank you. Yeah.
Okay, thank you. Dr. Huso, please respond to the literacy among migrant workers.
I don't think that I'm the right person to answer the questions in terms of education. So I have a delegate from the Singapore, Satish or Jeffrey or Stephanie. Do you have any? Why don't you say something about how we educated the workers or access to community resources in terms of settling programs? So we do have some program for education. Others, Satish, do you want to give some?
Good morning. I would like to thank you very much for sharing the information from the three presentations about analysis of COVID-19 control in the three countries. I would have one question, maybe for any example or all three countries. Was there any joint effort at the border between countries to communicate to neighboring provinces or countries to notify COVID-19 suspected or positive confirmed case when they cross the border? And if that happens, which information that could be shared across the two neighboring provinces of the two countries? And how did you deal with the migrants' privacies and data sharing across country for the COVID-19 suspected or confirmed positive case? Thank you very much.
Thank you. Dr. Tharani, could you please maybe respond? Okay, sorry. Okay, you can add.
Hi. Okay, regarding your question, we in Singapore, the Migrant Worker Center with the other organizations and all that, do have a series of programs where we ensure that a migrant worker, whether domestic or foreign worker, we find ways with various partners, with stakeholders to upskill them over a period of time. We do not want a worker when he comes, we call it ground zero. When he comes to Singapore, he's going to be here for the next 20, 30 years. If he doesn't do anything, I say stupid, he doesn't murder, rape, rob, he follows the rules and regulations, he's got a lifespan of 20, 30 years to work. During that span, if he comes in at ground zero, we want him, when he goes back at the age of 45 or 50, that is the age limit, he has upskilled himself, whether in terms of his verbal communications, in terms of getting a welding license, driving license, forklift license, so that when he goes back home, he has benefited himself, benefited his community, benefited his family. So we conduct a whole series of courses and programs, even teaching the workers, from the domestic side, English courses, financial planning, literacy planning, so forth. So they have a better understanding of how to take care of themselves, even how to run a small business. So this is all very important. You must always understand these guys are not rocket scientists. They all are from a very agricultural background and everything. So when they go back home, we want them to do better. And it's very much like what we went through with our families, our grandparents or great-grandparents, the whole migration. All our parents or great-grandparents didn't come in as millionaires or bankers or owned. They all came in at one level. So they always want their children to do better, their grandchildren to do better. And in that way, we find ways in Singapore to ensure that the migrant worker is taken care of. And they really appreciate this. We also ensure that all the small aspects from their physical, emotional, mental well-being is protected along the way. And this is done by three parties. One is the government, one is the employer, and one is by the NGOs and the community as a whole. That's it.
Okay, thank you. So, I would like to move to the question that raised by a guy here. Okay, so Dr. Trini, do you have any ideas about cross-border collaboration in terms of data sharing during COVID-19 in Malaysia?
I'm sorry, I can't actually answer your question directly because I don't have the direct information. All I know was there were cooperation, at least at the beginning when the borders were still open. We had a big tabligh event in Malaysia, and a lot of the first cases were being detected by Brunei, and then there were cases in Singapore and all over the region. And it was government-to-government contact and them sharing information that we could trace the event. I would really want to address the question that was asked earlier on digital health and digital communication. So this is a strategy that is really, we are moving towards. So during the pandemic, Malaysia had an app for COVID-19 management, and this was used for almost everything. It was called the My Sejahtera app. So everyone had to be registered on that app, and citizens, it's very easy. You put in your identity card number, your telephone number, your location, and so on. It would manage at every aspect of your life. Health information is given. Your risk status is on that because it's also part of surveillance, right? So whether you have COVID positive, that needs to be reported in the system. Whether your family members have COVID, it's all that. So your status is reported. It's also used for movement. Basically, when you visit a premise of any sort, you need to flash that and record that you've been there. Okay. We also use that app for vaccination. So we have to register to get an appointment through the app. And when we get vaccinated, our certs are in the app. And then the next appointment comes on. So basically, it's very important. Okay, so for non-citizens, this was an issue because, number one, health literacy. Okay, if they are illiterate, an app is not going to help them. Number two, the language. The language was in Malay or in English. It's not in any other language. Okay, the other thing is those who are illiterate, how do they get on it? Okay, very simply, those who are not documented, or how do they get on? So the issues actually came to a crux at vaccination. So the Malaysian government was very motivated to vaccinate everyone in the country, like most of our governments. So the strategy was to work with the app and how to get everyone registered, because there's only way to get vaccinated. So actually at the end of the day, it was working with community, it was working with stakeholders, NGOs, CSOs, international organizations, people on the ground, of having a different system of accessing the My Sejahtera. So people didn't have to put in their passport number and so on. Alternative methods of registration. Yeah, we had to be creative to make it work. So the idea about tech is really important, but you have to think about accessibility. Okay, another thing I want to comment is actually we admire the Thai system of providing healthcare insurance to undocumented, and I hope that that will happen in Malaysia too. The system of identity verification, getting a work permit, and getting health screening and health documents is very important. I mean, the pandemic shows you that you need to know who is in your country, so you can serve them and also protect everybody. Without that information, it's quite difficult to do anything. So this is something I hope that we learn. So to do this, you cannot have securitization of health. That identity cannot be misused, you know what I mean? Then no one will come forward anyway for the services, even if you offer it.
So I think for Thailand we have experiences about data sharing and international collaborations. Dr. Surasak, could you please share some experience from Thailand about cross-border collaborations and data sharing system?
Okay, thank you very much. In the past, the migrant health data system is not in the health information system at the Ministry of Public Health, but now CCS program or country strategy on the migrant health is developing the platform for migrant health data and information, and we involve the stakeholder now, just only the hospital under the Ministry of Public Health first, and then after this year we will coordinate with other sector, non-health sector, like a labor sector and security sector, to share the information system related to the health issue. Now, as Dr. Panuvit mentioned about the identify the migrants, undocumented migrant, we developed the iris scan and face recognition for undocumented by collaboration with the Thai Red Cross office, but now just only pilot at the 5 provinces in Thailand, and CCS program will expand the activity for iris scan in the other province. This is the method to identify the migrant worker who go to the hospital, and we will share with the other hospital in other provinces. And now, I think this year and last year, WHO office supported the budget to the Division of Health Economics and Health Insurance to develop the financial health data system for monitoring the health, migrant health in insurance under the Ministry of Public Health. And if you need to explore the more information, we can discuss in the afternoon for your understanding more. Thank you.
Okay, yeah, we have some points to add, please.
Yeah. Actually, the data sharing, if it's the COVID, it will mean for Thai legislation, we will consider is the dangerous diseases. So whenever we found any person, we suspected that it's imported case, we will notify to the original country. Either they are migrant or not migrant. So the data sharing for the dangerous disease is existing through the IHR National Focal Point team under WHO organization. So for the issue about the privacy of the migrant worker, whenever we notify the cases, we will not label the name or surname, but we must give some demographics such as the gender, the age, or something like that, that will help the originate country to do the containment or disease control.
Comment. Okay, works. In terms of the data sharing, monitoring, surveillance, etc., I guess there are some, we need to really kind of differentiate between public health data and health inequity data. So in terms of the data sharing, the COVID-19, whatever, that's all about the sharing public health data, not about the data on the health inequity. So if you really look at the address health inequity, we need to building up, assess, monitoring, sharing about data about health inequity, not about the public health data. Public health data is only about the descriptive, but inequity is as in a more normal way. So, I mean, just think about, but that's the kind of, even for the health inequity research study, are we looking at the public health data or are we looking at the health inequity data? Clearly, we need to look at the inequity data, not about public health itself.
So, any questions? Oh, please.
I'm Montira from IOM. Just have a question, and it's like, how did Ministry of Health involve other ministry or other sector in promoting health equity and inclusive health system among migrants, especially undocumented migrants? And I want to hear from all three countries, Malaysia, Singapore, and Thailand. Thank you.
Maybe from Malaysia, maybe any policy initiative to address and to support, I'm not sure, undocumented migrants you may have.
This is during the pandemic?
Beyond, both contexts.
Okay, I think I talked about the pandemic. So basically, vaccination was the best policy that we had. The Ministry of Health actually tried to be as inclusive as possible because, of course, they wanted to contain the disease. So healthcare fees were waived for people who are COVID positive. The problem was the securitization of health, and that was the power for that was away from the Ministry of Health. Okay, so undocumenteds were worried for being arrested. Post-pandemic, we haven't actually seen anything new. There are discussions about refugee health and so on, and how to improve that in terms of health insurance, but nothing concrete has developed as yet.
For Singapore, I think maybe undocumented migrants is not your issue, but maybe migrant workers with the problems with their status.
Okay,
like
so
that.
actually in terms of the health inequity engagement, there are some 3 steps: inclusion, participation, and then accountability. In Singapore, obviously we're including migrant worker community for the decision-making policy, so there is some development. Obviously we have some participation, so there is a voice. The problem is about the accountability. No one wants to be accountable. The reason is that, all the statistics Japanese show that is the health, the issues of migrant worker health is the accountable by MOM or MOH. I think that's the one issue that somehow all the accountability under the MOM or MOM is not the health sectors. So they want to put all the accountability to MOH, MOM say no, they are not our populations we serve. So I think that's the issue in terms of stage. You have some development in terms of inclusion, participation, but yet we haven't yet dared in terms of accountability.
Thank you. I just want to add on to what Dr. Husserl said. So during COVID-19, we did have a multi-ministry task force. The Singapore government did form a task force consisting of Ministry of Health, Manpower, National Development. So different ministries came together, but the purpose was to contain the outbreak. So the priority was to contain COVID-19 spread, both among residents and the migrant population. So we did have a task force that coordinated the response, COVID-19 response, and coordinated support for both migrant workers and residents as well. But when it comes to health equity, moving forward post-COVID-19, Singapore is officially in the endemic stage, so where we now learn to live with COVID-19. But now that the attention has shifted away from migrant workers, there aren't many initiatives. The multi-ministry task force has been dismantled in early last year when we went back to the normal phase. So there aren't any initiatives, task forces consisting of ministries to look at how equitable services are for migrant workers, or looking at even access to healthcare. And also for Singapore, migrant healthcare is now kept separately from the healthcare of the residents. So post-COVID-19, what the government recognized was that a lot of the migrant workers did not have proper access to healthcare. So that did result in increased burden placed on the health system during COVID-19. So recognizing that, the Singapore government implemented a primary healthcare system where migrant workers, depending on where they are living, in the dormitories or their place of residence, they are essentially empaneled in one of 6 regional medical centers. And these medical centers are operated by what we call anchor operators. So the government put up a tender, and for the medical operators who won that bid, they provide medical services in either one of these 6 medical centers. So now migrant workers go to the regional medical center allocated to them. Is indicated on their pass where they are, which regional center is nearest to them. But beyond that, looking at issues of health equity, looking at other barriers, we essentially do not have any task forces looking at these issues. But then by establishing this primary care system, what this does is that it still treats migrant health as a separate issue. So the standards, the regulation of services, the monitoring of how relevant, how appropriate the services are provided to migrant workers is entirely kept separate from the national standards that we apply to residents and Singaporeans. So along that route, we still do have, the primary care system is relatively new. It was, I think, established towards December 2022. So it's still new, and we don't really have any information disclosed in public about how it's monitored, how the standards of service are regulated, how the quality is maintained, because it's operated by anchor operators. And the Ministry of Manpower does have oversight, but the issue is also that I think similar to other countries, again, migrant issues are still treated as labor issues that fall under the Ministry of Manpower. And there is no coordination between Ministry of Health and Ministry of Manpower. And all these ministries operate in silos, except when it comes to managing crises like COVID-19. That was the only point of time where the Singapore government recognized that there was a need to also take care of the health needs of migrant workers. But now that we are back, the spotlight again has shifted from migrant workers, which is a concern now. So we still need to find ways to continue focusing on these issues and continue raising these issues to improve the prevalent barriers, the structural issues. There are still barriers to healthcare, barriers to equity for migrant workers in Singapore. So we still need to work on that. Thank you.
I think for Thailand we have many approaches to support undocumented migrants, but our financial support and resources are limited, so they need to be prioritized before accessing these services. I think it's our point. So any more questions from the floor? If no, okay, one. Okay, two.
Sorry for hogging the mic. I remember in Malaysia, there was a promise that if the migrants are happy to do their testing, to do the testing in the early days of the COVID, so there was a promise from the government that they wouldn't catch those who are positive. So they sent the Ministry of Health to do the testing, which was good. And the feedback from the workers was also positive for the first round of testing. But then suddenly that became a security exercise. So we felt that the data from the healthcare testing, which is another ministry, was then shared with the security-related ministry. And then the barbed wires came out and they went and did a raid, they caught undocumented migrants. So I think even though we talk about whole of society approach, there's a time when the ethics of data sharing should be there. Whether it's a firewall when the time is needed, but when there's a time not needed, there shouldn't be a firewall. So I hope more conversations like that can happen, because the next few rounds of testing, when the migrants saw the ambulance coming, all of them ran away. Ran. The whole areas just left. So you had something that backfired on the population. So hopefully we can have more discussion on the ethics of where do you draw the line, what type, and even if it's sharing information, what type of information. Now, at a macro level, to plan how many migrants there really are, it can be done. There's ways to look, remittance, telco. You don't need to do one-by-one surveys for the government to plan. How many undocumented, documented migrants? There are methodologies that can already answer that question. But for individual service providing, that maybe you need a different type of data. Yeah, so thanks.
Okay. So, okay. One more question, I think.
I don't have a question, but I'd like to share my experience with two notes before we go for lunch, I guess. So the first thing is about data sharing, because people ask about question how countries share data together. So based on my experience in Thailand and neighboring countries, we have learned that during the normal situations in this region, Mekong country, the country already established the mechanism called Mekong Basin Disease Surveillance themselves. I mean, among themselves, the country took initiative themselves, and the platform is still running. That's one. There's a mechanism to report or to do data sharing regularly. And the other things in terms of programmatic support. So I note that there are some what they call disease program like TB, HIV, malaria programs funded by Global Fund. They're already a forum and platform for a country to share the information, health data information together. But in terms of pandemic, so my experience with to support Thailand during the IHR mechanism to share the information of cases between the 2 or 3 countries, I had to say it's very challenging to share information. The information itself, and there is a platform to share information, but the issue, the challenge lies with the information of a persons. So either names, age, and also where they live in one country and move to another country where they seek healthcare. It's so difficult. That was happening during the pandemic when we really need to know the case and then take proper response. So this is something that I feel like maybe we can emphasize whoever work with migrants in the country in anywhere. So maybe something that they need to. We have to really encourage them to at least carry one card that they felt like this is their name. Otherwise, very, very difficult to trace and then do a proper public health response. And the second thing that I like to share is I've been working on migrant health issue for 20 years in my life, and I've seen a lot of progress in many countries. And what I learned is more and more we focus on the different, on the problems down to the operational level. It's also difficult to tackle the big picture. So what I see is addressing the health need of documented migrant is already complex. There are multifacets that we have to really factor in to address their health needs. And undocumented, even much more complex, much more difficult. So what I would like to urge everyone that don't forget that we have to also help migrants to make choice before they start to migrate into the country. If they migrate regularly and keep their status like documented, so their right will be protected easily. I'm not saying that we should not really, block their freedom of movement, but they should be informed before they move that being undocumented in another country, there are challenges that they will face, and also difficult for country to respond to their need. So for us, I think it's difficult. It's also something that we have to take back, that we have to work with others, entity, organization to try to minimize number of undocumented migrants. Thank you.
Okay, I think it would be the last question, and I agree with Dr. Ari that we need to improve the regularization and documentation for migrants, and it needs to have multi-sectoral collaborations between sending and receiving countries. So I think it's time for lunch now. Actually, we will have an hour for lunch. But before lunch, I would like to remind you our assignment for the afternoon session. I think the majority of you will get my email about the group assignment. Actually, in the afternoon session, we will divide you into 3 groups. And actually, we will have 3 groups of moderators as well. Actually, each group will be discussed about 3 topics, including access to healthcare services in migrant communities and healthcare settings, social determinants of migrant health, and cross-border collaborations for migrant health and protection. So the list of your group will be available both sides of the meeting. You can scan it and look at which group you will be allocated to. So actually, after we finish the discussions for the 2 themes, we will take a break, and after the break, we will have only 1 theme left. And then when we finish all the 3 sub-themes discussion, we will have a group presentation, and the moderator will deliver the summary of the discussions from your group. Actually, for lunch, please be informed that your lunch will be available on the 22nd floor, the downstairs. You can show your badge for the staff in front of your lunch room, and then you can enter. Okay, so we will have around 1 hour for lunch, and thank you so much for the morning session.
เส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพโดยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังสุขภาพคนไทยท แบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย ความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยร่วมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพโดยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร เข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานกันและความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเครือข่ายให้กว้าง ากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมเพื่อสร้างด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย และความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาธรรมร่วมประสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพโดยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานผลักดันความรู้ ต่างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานกันแต่ความรู้รวมคิดรวมทำเพื่อขับเคลื่อน ตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย เดินต่อไป สานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้า คิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเดินต่อไปสู่วันข้างหน้าสืบสอบค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วัน
going to get started with some instructions. Okay, hoping that everybody had a very, very nice lunch and managed to find some time for dessert as well. If I could get all of your attention just for a very, very short few minutes, please. First, thank you. Okay, first of all, I just wanted to thank all of the presenters for this morning. My name is Tamsin Fernandez-Cox. I'm from IOM's regional office from Asia and the Pacific. I think we listened to a lot of very, very interesting presentations, which were both very analytical of each individual's country response, looking at both the positives and the negatives. And I think that's incredibly important, right? So thank you very, very much to every single, participant and country that did self-analyze their own, national response for the positive and negative. So I think, I think there are some of the key things that we heard this morning. We have to work harder at the end of the day to move towards universal healthcare. For migrants, it doesn't matter whether they are documented or undocumented. We know that exclusion costs lives, right? Not just migrant lives, everybody's lives. So we have to continue working towards UHC and ultimately away from the securitization, right? We also, at the end of the day, learned that we need to enhance data, and we've got to move further towards enhanced data sharing. We heard also from our WHO colleagues and our Thailand colleagues about the national assessment, which is a fantastic tool. Again, we heard about the concrete needs for enhanced multi-sectoral coordination and collaboration, and how at the end of the day, we're all, at the moment, seemingly operating in a little bit of a post-response modality, right? But, as we've said, COVID-19 was not the first pandemic, nor will it be the last pandemic. So I really want, in our next session, for you to please be thinking practically about how we move from this post-response, right, to a preparedness and readiness. How do we, at the national, regional, and global levels, actually move to prepare for the next pandemic and ensure that we save more people's lives? So please, in this next session, think about solutions. Please be practical, because I'm sure you are aware, but the aim of the next session is to solicit proper policy inputs that could actually be used, okay? So we're very, very excited for this. We're going to be discussing questions under three main themes. So domain one is looking at healthcare governance and access to healthcare services for migrant communities. You have a number of questions at your desk, so please, we hope that you discuss these as a group. Number two, we shall be looking at social determinants of migrant health, which encompass working and living conditions, preventative health, etc. And under domain three, we're looking at cross-border collaborations for migrant health and protection. Now, every group has these questions which you must discuss, and you must come up with practical solutions. And please do think at the national, the regional, the cross-border, and the global level, okay? So we're really looking for you to not just think nationally, but please think a bit more holistically about how we can come up with some good answers to these questions. Now, we have our lovely moderators and our lovely rapporteurs for each group as well. So I'm hoping they will stand up when I say their name. So for group one, access to healthcare and migrant communities, our moderator will be Associate Professor Tarani Loganathan. Thank you so much. And our rapporteur will be Miss Amira Zafira Zaini. Thank you. For group two, we have Dr. Momin Nader as our moderator, and our rapporteur, Ms. Aisha Farwin. For group three, we have Dr. Man Hung Bui as our moderator, and our rapporteur as Ms. Divya Lokhotia, sorry. So each group will have 40 minutes, okay? So it's actually not a very, very long time. You may decide among your groups how you split the questions, which will be decided by your moderator. So we'll have 40 minutes. Moderators will walk around the groups, and the rapporteurs will collect all of the information and the practical solutions and policy recommendations that you provide, okay? So only 40 minutes for this exercise. And then, as we go on throughout the day, after the tea break and so forth, each group will have 15 minutes. The moderator will present what each of your policy recommendations were for each of your questions, and whether this be, as we said, at national, cross-border, regional, or global levels. Does everything make sense? Okay, wonderful. All right, guys, let's change the world. Thank you. 40 minutes, thanks. everybody kindly asking that the moderators get ready to switch. So how group 2 is working, they may switch between the group 2 groups, and then we will ask the moderators for group 3 and group 1 to kindly switch places. So please finish your conversation points, and then group 3 and group 1 switch, and the 2 in group 2 switch. Thank you. Hi everybody, you have until about 5 past, 10 past 3 to discuss this next area. about 10 minutes left, so please make sure that you get through all of your questions before the refreshment break in this group. Thanks, everyone. Okay. Thank you very much, everybody, for your hard work over this period. We're now going to have a 15-minute refreshment break, so 10 to 15 minutes maximum. And then you're going to come back, sit back in your chairs again, and we'll have another 40 minutes. And you're going to get the new moderator one more time so that you do all 3 sessions, okay? So please, 10 to 15-minute break, come back refreshed for the next session. Thank you.
ทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย ส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลัง เส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่ว
the police force or the services or whatever. Even the migrant movement, we had two groups of migrant movement. One group, almost 370,000 were locked down in the dormitory for 6 months. Then there were another groups of around 10 to 15 who still needed to cut the grass, do this, sanitation. You couldn't do it, the country would die. You still needed to them. So these were still taken care of. I can't just let them go out on the road. I still have to provide PPE suits for them, make sure their meals were taken care of. All of this was done. We didn't segregate. So I think that's where you have to have that key private-public support coming together to ensure. And one of the things that we did was we had a lot of private sector companies who came to the biggest organization of the Temasek Foundation. They pumped in money. But a lot of the other private sector came in, and what the government did was, if you pump in X amount of money, you get 2.5% tax exemption, and the government will pop out another 3 to 1. So if Adrian gave $100,000 to go and buy masks, you'll get 2.5% tax exemption, 250%, and then I will pump in another 300,000. And I'll use the $400,000 to go and buy masks, hand sanitizers, X, Y, Z, or whatever. Because all is
Yes.
Question. So, if you're talking about universal healthcare, ensuring the cost of medical treatments are equal, that will, really return the subsidy back. Will that?
That's not universal health coverage. That's pricing.
Pricing.
Yeah. When you talk about universal health coverage, what is accessible healthcare and not being financial. So
that's a burden.
Yeah, so
the idea
of it is IPPM services, or you have like a house. So at the point of coming to seek care, you're not paying an amount that you need. I feel that Malaysia needs to have a weird pricing that's fine, it's acceptable, but we should provide insurance for all. For those people who are coming to our country, they have a mechanism. If they're coming to work, they have a mechanism to get insurance, which they do. But the others as well, the undocumented refugees, sailors, they should have some mechanism to protect them. So this is the kind of response that we should be having. And it should not be confined to time of the pandemic, because it's not time of the crisis. So it's crisis.
So the scenario plan projection, let's say 2025 when another pandemic happens, we should be able to show.
Even if a pandemic happens this year, we should be able to see something. We can't be back to square one again. So then they'll be calling UNHCR to do this and do that, calling Adrian to go to this corner of the world.
But the scenario planning, have we done that? We have done it. So like in terms of, I can tell you in terms of stockpiling, in terms of key essential items like rice, salt, sugar, all the items, even toilet paper, everything. Our NTC pack rice is stockpiled. We have learned the lesson. We are not perfect. We have learned the lesson. And what we need, even medical, ART kits, now, we have stockpiled everything. And there is the task force is better. But senior people still get every 3 months. We also took feedback. We saw what's happening in America, what's happening in Australia, what's happening in other regions. We also understood, the movement control order. Why were people not taking their vaccination? Were there people actually getting sick? So it was a learning curve. It was a very steep learning curve. I can say, honestly, in Singapore we are prepared now. We learned the lessons from SARS. We thought SARS.
Final 10 minutes, everybody. Thank you.
I would like to move on to the third question. So reflect back to the question. The question here mentioned about people of the workers who leave your country to go to other country to work, and because of health condition, they cannot work in the country anymore. Return to your home country. Is there any health insurance system for them? So what I learned if you return, you can live home. So that is fair enough. And Singapore and discussion here.
Final 2 minutes. Sorry, guys.
So I know this is moving on. Let the last question for me, and we have only 2 minutes. How can sending countries and receiving countries establish effective partnership to improve labor and health situation of migrants? So the country here that we go, receiving the same so as a sending country, what do you think that we need to do to establish your country and receiving country? If you are a receiver, how do you work with the sending country to ensure healthy workers come to your country and they have
Okay, everybody, sorry to interrupt you. I know there's many more things that can be said, many more ideas. I would like to ask all participants to please just enjoy a 10-minute quick toilet break, coffee break, and for the moderators and their esteemed rapporteurs to very quickly, for the next 10 minutes, put their presentations together. Thank you so much. We'll see you back here promptly at 4:10 in 10 minutes to start. Thank you.
ด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าว ส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลัง ำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อ พื่อสุขภาพคนไทยทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยเส้นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อน เครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทย
Moderators and our rapporteurs were very, very quickly trying to synthesize all of your inputs. So we will now proceed with the presentation section of today. The idea is that each group, each moderator and rapporteur will have only 15 minutes maximum to relay the key information. So with that, I would like to invite the first group to the podium, who will be discussing access to healthcare services in migrant communities and healthcare settings. So if I could please invite Associate Professor Tarani Loganathan from the Department of Social Medicine and Public Health, Malaysia. And of course also, thank you. And thank you very much to the rapporteur, Ms. Amira Zafira Zaini.
Okay. Thank you so much. The first domain was on healthcare governance and access to healthcare services for migrant communities. I would like to thank all the participants here in this room because of all your hard work and so many comments. We just managed to condense it down to a few points. But of course, there'll be a lot more work later to interpret what you've said. Okay. Not moving.
Next slide.
Okay. So the first question was, are there legal systems available for migrant workers to ensure access to quality healthcare? And how effective are these existing legal protection systems in ensuring their access to healthcare? So mostly what we gained was there's very little legal mechanisms to ensure migrant health, either in sending country or receiving countries. Okay, some countries have partial protection, like Thailand. They have universal health coverage law, but that only covers documented migrant workers. But it seems that nations also have UHC or insurance schemes are not actually through legislation. So that mechanism also works. Suggestions, this is based on discussions with the groups, is bilateral agreements are the best option. So between the sending and receiving countries, cooperation and cross-border agreements on healthcare and management of patients, sending back patients is the best option. The consensus was the role of ASEAN and so on, and other international agreements have less weight or less power in this space. There was also a suggestion that's pretty interesting. The idea of portability of health insurance between borders need to be revisited. So this conversation is not new. It has been visited in ASEAN before, the idea of having a health insurance from the sending country, and that health insurance can be applicable in the receiving country. So the migrant worker has some coverage based on that. Next slide, please. Are there professional and ethical guidelines that ensure equitable healthcare access for migrant workers? There are guidelines and regulations in most of our countries on quality healthcare practices for medical services and healthcare practitioners. Okay. However, the mechanisms to report or seek justice for negligence and misconduct is lacking. And what we say, when we say lacking, it's not lacking as in it does not exist. The mechanisms are there, but it probably takes too long. Okay, and migrant workers are not aware of how to do it. Okay, they are not aware of how to do it. They also might be afraid of doing it because if they report, they might be terminated or would get into trouble with their employer. So this may need to be looked at. Strategies for improvement. One is to train the workers themselves or the community, improve their awareness of what is available and what is available for redress and their rights, and also to train healthcare providers on fair practice or quality care for non-citizens. Okay, so one of the points that came up during discussion is a lot of times quality care may not be what we think is right because actually language is not, there's a lot of miscommunication. Okay, so it may not be intentional. So in that sense, one of the strategies for improvement is to have translators and interpreters service. The idea of the community health workers or community health volunteers implemented in Thailand is something that we should look into in our home countries as well. Okay, so the next two questions. Are there avenues to allow for coordinated efforts between stakeholders to address systemic barriers to health equity and inclusive healthcare? What needs to be done to improve collaborative efforts between stakeholders to achieve the goal of healthy migrant workers at the community and population level beyond individual migrants? Okay, so I think most of us, in most nations now, the post-pandemic impetus towards cooperation towards improving migrant health is lacking. Okay, so in national levels, I think the issue again is who takes ownership of migrant health, because ministries of health may not see it as their responsibility anymore. And financial commitment was listed as one of the main reasons. So who is going to pay for it if you're going to provide services, build hospitals, or provide insurance? So I think one of the main reasons identified is the lack of leadership and responsibility for sustainable governance for migrant health. And most of us agreed that it should be actually, the leadership and governance should come within the government of the day and pretty high up, because then you can involve different stakeholders that are in government and people in the country, the CSOs, the community, and different partners internationally. But that governance should come from the government. So suggestions are if there are global funds for governance for migrant help and international pressure for commitment. This one is actually a bit tenuous because actually in all our SDGs and so on, migrant health is there. And I think there is a lot of focus on this, but when it comes to national level, to take that responsibility is still difficult. Okay. Any questions? Thank you.
Okay. Thank you very, very much for that interesting presentation and synthesis. Hoping that we can put the second presentation up on the screen to our friends over in technology. It's on the social determinants of migrant health, please. Thank you very much. And in that regard, I would like to invite Dr. Momin Nader to the stage, please, to present. Thank you very much. Oh, hello.
Hello, everyone. So first, I would like to thank our rapporteur, Aisha, and I would love to thank every one of you for the great contributions you did for today's session. Next slide, please. So, as you know, we had 5 questions asking about structural, social, and cultural barriers, how to address them, public and community-based initiatives, and then a platform that brings migrants and policymakers together. Next slide. This diagram just explains the questions that we have, how we aim to reach a migrant-friendly and inclusive health system. Next slide. So we were tackling these 5 questions through to identify the social determinants of health through the 4 phases of migration, starting from the country of origin, transit, destination, and return, looking into individual characteristics, working condition, living condition, and the socioeconomic status. Next slide. So there are 4 IOM priority areas, from monitoring migrant health to policy and legal framework, migrant-sensitive health systems, and partnerships. Those are the main 4 areas that at the same time we actually use to answer these questions. Next. So from structural, the first question, what are persistent structural, social, cultural barriers to good health among migrant workers? The first and most critical was actually the lack of policies related to migration, not only to health, but related to anything starting from registration process, legal identity, and how actually cross-border collaboration between countries. The second point was about lack of collaboration between ministries, because migration is a multi-sectoral issue. So the issue is not only with the Ministry of Public Health or special institutions, while it has to be a multi-sectoral approach that gathers everyone, all stakeholders, private sector, CSOs, and the ministries. Next was exclusion from national demographic databases. So migrants' data are not captured by the national systems. So we do not have enough data so that we can develop policies and implement them and force them. Which comes to the next point, which is cross-border coordination. Because I don't know how many people are crossing from here to there. We cannot refer them. We don't know how to track the migrants. If a case has a TB and want to be referred to the other country, I cannot track that patient. Next slide, please. So we had also cultural issues, which were summarizing stigma, discrimination, and xenophobia. In addition to the focus that migrants come to the country of destination to save money for economic reasons. So the last thing that they want to do is actually to pay money to receive health services. They don't know how to actually access health services. They don't have accessible information to receive these services, so they just focus on saving the money, while actually they will only seek health services in very, very severe conditions. financial barriers, we talked about the debts that actually people pay too much money to be able to migrate to another country. So at the end, once they arrive, they cannot spare any source of money to pay for anything else except paying their already existing debts. And finally, language barriers to access information. Next slide. So when we talk about how to tackle these barriers and are these sufficient, I believe that we all agree that these ways to tackle were not sufficient. That's why we have still persistent problems, and that's why we actually look into these ways to find a solution is more of recommendations of this presentation. First, laws and regulations to protect migrants and ensure health access. Second is adopt equitable policies, access for undocumented migrants. I believe that the most issue that everyone talked about was the lack of legal IDs, either passports and IDs. And special countries like Myanmar, for example, mentioned the issue of countries detaining the IDs. So each country had a specific situation. Migrant-friendly health system, and Thailand was a good example for the migrant health volunteers and migrant health workers who can support the migrants to access these services. But for example, at the same time, healthcare professionals from other countries are not recognized to work in Thailand, which is still a policy that other countries see that it's blocking a lot of migrants to have migrant-friendly health system. Other solutions are reflecting the problems like the databases and the cross-border referral system, but at the same time, one of the groups mentioned the role of the embassies of the sending countries to support actually their own citizens. Next. Then we have complicated registration processes, which in some countries like Myanmar actually goes into many phases that lead to internal migration, which makes the process more complicated. There are minimum standards of housing and work condition that needs to be taken into consideration. And even some countries may have some laws that can allow the migration process to take place smoothly, but these laws are not enforced. In addition to improving health literacy and labor rights. And as we mentioned that there are many processes and complicated processes, this leads to private sector to intervene, which costs a lot more money on the migrants themselves. Next. So I will address these two questions together. Are there like public and community-based initiatives? Most countries had, yes, public and community-based initiatives, starting with Thailand. The government, especially with COVID-19, developed a lot of initiatives on health education in different languages. But also there are different initiatives related to health insurance and achieving universal health coverage. And for the community-based initiatives, it was mainly the civil society which were responsible for migrant health workers and migrant health volunteers to support the migrants' access to healthcare. For Singapore, it was almost the same, but mainly during COVID-19, not much outside COVID-19. But for CBOs, migrant workers are not taking part in this response as much as it's some organizations by Singapore that can support migrants. Next. So the last question were there platforms, official platforms, to bring migrants to policymakers. In Thailand, there was the Migrant Health Working Group that can bring NGOs representing migrants with the Ministry of Public Health and different institutions. But in Singapore, the only way was actually through NGOs. I hope we summarized the points. The points were too many. We thank you so much for all your inputs. Thank you.
Thank you so much, Dr. Momin and everyone that contributed. I hope you all enjoyed the free IOM presentation as well that you got during that. Okay, so without further ado, if you could please put the third presentation up on the screen. Great, thank you very much. Okay, and with that, I would like to invite our moderator, Dr. Man Hung Bui, also from IOM Vietnam, to the stage, please. He'll be discussing, no, please come on in. Cross-border health collaboration in relation to migration patterns, migrant health profiles, and health vulnerabilities and services.
Good afternoon. Thank you for your attention. And I would like to say thank you to Divya who helped me with taking all the notes and putting in to presentations that I have the privilege here to share with you. And all the information here, also thankful to you because it comes from your initiative and your input. And I just only add a little of my rationale to make it more flowing. I would like to mention each of our questions in terms of topics. So the first topic we discuss among the groups are challenges in fostering cross-border partnership or relation between sending and receiving countries in protecting and enhancing the health of migrant workers. At the national level, it is commonly known that there are MOUs and cross-border collaboration between countries existing. But this collaboration is not fully functional or fully implemented, and health, migrant health is still not considered as the agenda between collaboration between the two countries. Nationwide, lack of multi-stakeholder, multi-sectoral, multi-ministerial collaborations, including collaboration between public and private sectors and with other NGO and international organizations may also cause a challenge in effective cross-border partnerships. And investment is also mentioned in our discussions because migrant health, migrant workforce are all investments. And it's not only about the resources, but also the infrastructures that leads to the implementation of tangible, successful outcome, which means is to be able to make any investment to be sustainable, it needs to be included in the national action programs. And it's been mentioned by previous presenter that when it comes to be sustainable, it needs to come from the initiative of the owner and the ownership of the nations, of the countries that are supporting the migrants. And the budget, which also make any program sustainable, is also have to be committed by the central government of each country so that the activities can be implemented from year to year and it doesn't be limited by any projects. And finally, the challenge that we see in fostering the cross-border collaboration is a lack of resources mobilizations. For example, we have an example here of Thailand example. Migrants who already took the pre-departure health checkup in the sending countries when come to Thailand need to do another checkup at the border again. So that would be double paying for the cost of diagnosis and also health checkup. And this is also related to resources and mobilization of the resources of both sending countries and receiving countries. Our second topic is talking about transnational migration that ties to physical, mental, and social health of migrants in both and between countries. So there are three terms mentioned here related to health: physical health, mental health, and social health. And all countries agree that in terms of physical health, it's well guaranteed in both sending country and receiving countries, and it is regulated by public health securities regulations. However, mental health and social health are relatively new concepts, and especially gaining more focus and attention during the pandemic. However, at this stage, when the pandemic is nearly over, there are challenges associated with this. First is language barrier. It's very hard to consult with the migrants when language is a barrier. And we are here coming from different countries, non-English speaking countries, but we all speak English here, so that is also the barrier that we need to speak a foreign language before we can communicate with the host community. And in addition to language, there's also cultures related to the sending country and receiving country that have impact on the mental health and social health of the migrants. And finally, that would be sustainability of the program to support mental health and social health before becoming a national programs that focusing on migrants. One example that we heard from our Cambodian delegates are migrants coming to Cambodia are usually higher skilled workers, so they have better access to health service. They are covered by health insurance. But in Cambodia, the ones who are more vulnerable are Cambodian workers who may have struggled with their mental health, social health, and physical health. So the context here is very important for each country. For example, in Thailand, when talking about migrant, it is implied like non-Thai people working in Thailand. But like in Cambodia, from our Cambodian college, or in Vietnam, in my own country, when we talk about migrants, we're talking about Vietnamese or Cambodian migrants going to other country and works. So when we talk about even the word migrants, it may be different understanding and interpretation of the term, but it's good that we know that mental health and social health are newly innovative areas that will be focused in the near future. Okay. The third question related to whether or not there is any health and social care system for returnee when they return to their home countries after being unable to work at the receiving country due to health conditions. So we have listed here comments from the delegates of different countries in Thailand, Laos, PDR, Singapore, and Cambodia. Migrants who return to their home country for whatever reason may have access to healthcare services as long as they have the ID card for Thailand and as long as they're under the national insurance schemes for other countries. And especially in Singapore and Thailand, they have the scheme for compensating worker injury during occupational health and occupational injury. On the other side, in Myanmar or in Vietnam, the returnee hasn't had any policy to support them directly upon their return to their home country yet. So IOM directly support the people who are vulnerable and return to their home country. In this context is Myanmar and Vietnam for these two countries. Then we talk about the equitable monitoring system for health status for migrant workers. And I realized that when crossing all the groups, the term monitoring system can raise a lot of alarms. And it may cause many confusions. We're talking about monitoring system and the needs of sharing the health status of migrant workers. What is the need and why we should do that? So first of all the group talk about the need to be consensus on the decision of the ownership of the monitoring system if it ever exists. So if two countries share the same monitoring system, who will own it? Who will manage it, that system? And who will actually fund that system to run? So that I think that's the more important questions. Secondly, data privacy, and that issues a lot of difficulties. For example, it is mentioned by one of the delegates that population information, like general information of the small population, can be shared and transferred between countries, but individuals' information, especially health information, cannot be transferred. So that would pose the challenging aspect if we mention about cross-border transfer, software transfer system. And one example that was mentioned is even the medical services or medical treatment in each country is different. In this case is HIV/AIDS medical treatment with ART. Different countries have different regimen to treat HIV/AIDS positive cases. So the ability for the migrants to access health service is very important and also need to be managed and monitored. Because if the person do not receive the same kind of healthcare procedure and healthcare treatment in the receiving country compared to their home country, it might pose a problem. It might cause to other unexpected outcomes that we may not know. And some informations are already available and being shared. So in the TB programs, it is mentioned that the TB X-ray screening data is ready and available to be shared across the NTPs of the relevant countries. However, it is emphasized that only information during or in case of public health emergency can be shared. Any other information that related to personal information must obtain the consent from the migrants before able to share or to others, to share, but also to transfer to other countries. This is to protect migrant workers from any harmful or unnecessary surveillance. That was the term that one group used. So among all of four above topics that we discussed, the group would like to pull out few recommendations for effective partnerships between sending and receiving countries with the purpose to improve labor and health protection for migrant workers. So at the national level, bilateral agreements between governments of sending country and receiving countries need to include the benefits of the migrants, and the migrants need to understand what benefits they would have under these bilateral agreements or regional framework. At the country level, multi-sectoral, multi-ministerial collaboration is required, and this would point out the champion or the champion group of agency that will focus and to lead the migrant health agenda. Also, harmonization of international standard of health and well-being of migrants is very important. And in Thailand context, only one example here, many ministries also join in the group to support migrant workers, especially during the COVID-19 pandemics. The challenge here is among those ministries, there's no champions. So it's very hard to mobilize all of the agency at once to focus on one topic when there's no one to take charge or who lead the group. And finally, for the recommendation of cross-border country-to-country partnerships, the groups recommend to host up regional conferences or high-level collaboration meetings and cross-border workshop within national and also provincial contexts, so that both from national and provincial and at grassroots levels, all participants can join and understand the importance of their activities and their work in supporting and protecting the health of migrants, but not only for the migrants, but also the public, the communities that the host countries is so also welcoming the migrants. So here's are the few analysis and recommendations from all of you. And I would like to thank you very much for your time and consideration. Thank you for your input, and I wish you a very, very good success. Thank you very much.
Okay, everyone, thank you so much. I would like to just briefly ask, of the three presentations, are there any significant things that you think may need to be added or amended? And of course, just briefly give you the opportunity to note that. Yes. And hopefully we can take these notes down somewhere. If you tell us which, whether it's 1, 2, or 3.
Sure. I'm not going to be repeating this. There's one critically, significantly missing point from the all good, but I guess even within the migrant population, there are certain groups need more care and more attention. There are the children of a migrant family and the gender woman issue. I think that has not been addressed at all. So clearly, I mean, we look at the equity issue. The children need more care, especially the education, the health issue, and the women need more care. So I think that's certain point that, we only look about the sort of horizontal equity, but there are certainly the vertical equity. Someone who are more worse off from the migrant population, who need more attention, care, and resources, I think that needs to be addressed. That certainly we need to somehow to prioritize what other kind of immediate action to be taken. So I'd like to point out that there are some prioritization on the migrant policy, even for the workers who are injured or need to be sent back home, that there needs to be special care for those people. So, just look at Singapore. Singapore, we only look at the healthy young migrant population. they're okay. But if you look at other countries, certainly there are more groups need more care.
Thank you. Yes, absolutely. I think, looking at all of these ideas, it's going to be impossible to formulate pinpoint, specific, disaggregated, policy recommendations from just ultimately an hour and a half to 2 hours of conversation. And having, consulted with colleagues, these are kind of the starting point. So basically all of your inputs today will be consolidated, and then there will be an additional meeting to again revise and review everything before they're sent to the ASEAN SOM HD for refinement into policy recommendations. So I think what everyone's done today has been really fantastic and really, really important, especially because I know that we have stakeholders from lots of different areas and of course from the different countries. So today's been a really good example of multi-sectoral coordination and collaboration and a real meeting of the minds among so many different people. So I would like everybody to just give themselves a quick round of applause. Thank you very much. And I know it's a long and tiring day. So without further ado, thank you very much to the moderators and to the facilitators. And I would like to invite Dr. Wana Hanshawarakun, a medical physician with the Department of Disease Control, Ministry of Public Health, Thailand, to the stage to provide summary and closing remarks.
Thank you very much. Actually, I think the meeting is already summary summed by the facilitator and also your guide. And actually, they invite Dr. Sopon, the Deputy Director of the Department of Disease Control, to give you a closing remark. However, he have more very urgent mission that he cannot come and request me to come. Probably because he think that I am the one who are the main stakeholder, because I am the employer of one migrant worker from Myanmar. So I understand this topic quite well and got the most pain point from all the process. And also I am the health worker. As a professional, I should taking care of health for her as much as myself and my family. I mean, because the closing remark is quite long, and I think it's a long day for all of us. We are very tired, so I would like to just say thank you to the organizer, thank you to the speaker, thank you for the facilitator, and all the participants, especially the back office as a registration or administration, and hope all of you have a safely travel home and enjoy Bangkok for the one who will stay longer, and hopefully the migrant worker will have a healthier and better quality of life and equitable access to medical care and preventive care. Thank you very much.
And just for one final thing, if I could please invite Ms. Bunyawi Awan Sirewan, a research manager in health systems at the Research Institute Thailand, very briefly to the stage to thank Dr. Wana. Thank you.
นทางแสนไกลยากลำบากเท่าไรเราจะค้นจะหาสร้างความรู้ใหม่ๆสร้างสรรค์วิจัยเพื่อคนไทยทุกคนเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้างหน้าสืบเสาะค้นหาพัฒนาในทุกทางด้วยความตั้งใจเราไม่เคยหยุดยั้งสวรสรวมพลังเพื่อสุขภาพคนไทยร่วมมือประสานผลักดันความรู้ร่วมคิดร่วมทำเพื่อขับเคลื่อนสังคมสร้างพลังหลากหลายวิชาการนโยบายและประชาไทยรวมผสานด้วยกันเสริมสร้างเครือข่ายให้กว้างไกลสร้างความเข้มแข็งของระบบสุขภาพด้วยปัญญาและความรู้เราแบ่งปันเป็นหนึ่งเดียวก้าวเดินต่อไปสู่วันข้าง